Okay.
Yes, we can see your
So
screen.
yes. So today we're going to start with non-invasive intracranial pressure monitoring. And so again, intracranial pressure monitoring is a very important part of the neuro, critical care. So you can always correct what you monitor. That is the dictum. To introduce myself, I'm Dr. Muthu Dharnendra. I am consultant critical care medicine and head of the department at Aster Ramesh Vijayawada, Andhra Pradesh. So we have been basing this talk a lot on the recent published journals. So this is one of the very interesting review in Journal of Clinical Anesthesia. So non-invasive intracranial pressure assessment in adult critically ill patients. So non-invasive is the way to go these days, especially if you are in the periphery, you're in the remote location, and you're in non-expert neuro critical care centers or neurosurgical centers. So starting with the monitoring, you have, based on the complexity, intermittent, semi-continuous, and continuous. So in the neuro monitoring, intermittent is anything that you do it in intermissions, and you cannot do it continuously. It includes radiology, ultrasound, and semi-continuous pupillometry, transcranial Doppler. You can repeat it at bedside frequently. At the same time, you can repeat it unlimited amount of times. There is no radiation to the patient. There is no cost to the patient. And continuous monitorings are like transcranial Doppler. You can use it continuously if you have the right headset with you, and pupillometry also you can use it, but semi-continuous at the best. So intracranial pressure reflects the skull contents. Okay, so what we are measuring the skull contents. We are measuring the intracranial pressure. So intracranial pressure is the factoring of the skull contents. So the brain, the parenchymal component, the CSF component, the blood component. In the blood, we have the arterial and the venous side. So elevated ICP threatens cerebral perfusion and survival. Invasive is actually the gold standard, but non-invasive methods, you can have it do it at lower risk, lower chances of infection, and they're easily repeatable. And especially in centers where you are not having the expertise to do the invasive monitoring, you can always stick to non-invasive methods, and its role is increasing in ICU. So there is a recent review article from Ropeke et al. So it was published in World Journal of Critical Care Medicine in 2025. I will enclose the reference article also. So why monitor ICP? So to guide therapies in traumatic brain injury, stroke, meningitis, help to prevent secondary brain injury. So the primary brain injury has occurred at the time of the insult. So we have to prevent the secondary brain injury. The secondary brain injury includes hypoxia, hypercarbia, hypotension, and all these factors. Yeah. So the normal ICP, as you know, anywhere between 12 to 18, and once the ICP increases more than 20, more than 25, there is intracranial hypertension. So there is an excellent article by Rubania et al. In Intensive Care Medicine in 2025. So this curve is the non-invasive ICP monitoring curve. You can see that during various stages of increase in intracranial pressure, there are different clinical signs and neuroradiological signs. So this is one slide I want to get across to all my, all the audience today. So you can see when this is normal ICP, the clinical findings. So GCS is normal, normal pupils, and all your other parameters are within normal limits. So as the intracranial pressure increases, as the intracranial contents increases, initially there is a compliance. So there is a accommodation. So first the venous blood volume goes down. The brain tries to adjust for the increasing intracranial content, and once the compliance reaches the ceiling, the intracranial pressure increases suddenly. So when the intracranial pressure starts increasing suddenly, you start to have clinical signs, and you will start to have all the bedside changes in the transcranial ultrasound, optic nerve sheath diameter, and everything. So the first thing that we commonly see in the ICU is the clinical changes. So patients start to complain of headache, nausea, vomiting, and if you do the transcranial Doppler, you'll see flow changes. If you see the optic nerve sheath diameter, you'll see there is an increase in diameter more than 5.5 centimeters. So this one slide I want to get across. It is derived from one of the latest review articles in 2025. I'll post it at the end of the discussion. So what are the limitations of invasive ICP monitoring? As we discussed, infections requires neurosurgical expertise, and the patient might be having coagulopathy. He might be on any oral anticoagulants, factor 10A, factor 10 inhibitors. So you might be on many of these things. So again, requires expertise, and coagulopathy is the limiting factor. Non-invasive monitoring is progressively being used because of its safer nature, and you can use it bedside and you can repeat it. That is the main thing, especially transcranial Doppler ultrasound. Once you learn it, you can repeat it, and you can use it for many number of common neurological pathology that we see in the ICU. For example, subarachnoid hemorrhage. Okay, especially in resource limited settings. So non-invasive methods, you can classify it as ultrasound based, optical based, mechanical based, radiological, and emerging, emerging trends like nurse. Okay, nurse is one advantage is it's very easy to operate. Once you know how to read a nurse, it is very easy to calibrate and operate the nurse. It can be used continuously. And optic nerve sheet diameter and transcranial Doppler are one things that you can do readily, and you can, and the learning curve is also very plateau. I mean, you can easily learn it. It doesn't have a high gradient. And the basic thing about optic nerve sheet diameter and transcranial Doppler is you don't need to move the patient out of the ICU. No additional cost to the patient based on your institute, and you can repeat it again and again. No radiation risk. Okay, so this is the optic nerve sheet diameter. So I will just explain briefly how you place the probe and all that. So what we are doing in optic nerve sheet diameter is you're measuring 3 millimeter behind the globe. Okay, so this is the eyeball, and you measure the optic nerve sheet diameter 3 millimeter behind the eyeball. So the expansion reflects a raised ICP. The threshold is 5 to 5.7 millimeters in adults. Okay, it is reliable in traumatic brain injury, stroke, and even hepatic encephalopathy. And in pediatrics also you can use it. But the problem is it is operator dependent. You need to learn it, just like your focus, just like how you learn the focus in the ICU. You need to learn the optic nerve sheet diameter. Okay, so the thing is you can use the phasic array probe or the vascular probe. The thing is you need to inform the patient that we are going to, especially when if the patient is conscious, no, you should explain them what you're going to do. Okay, and you can use the ultrasound jelly, and you can use a transparent sheet so that you prevent it to enter the eyeball. Okay, and you can angulate the probe and you can optimize the image. The main thing is calculating the diameter just 0.3 millimeters behind the eyeball. And transcranial Doppler, again, one bedside thing, which you can repeat it again and again. So basically, you're measuring the cerebral flow velocities, and ICP is inferred based on the pulsatility index. Okay. So again, the advantage is you can repeat it again and again, and the velocity changes are very specific. For example, the velocity flow increases. Okay, that means there is going to be a vasospasm. So that means you need to increase your cerebral vasodilator dose. So it is very dynamic. It is bedside, and it is repeatable. Okay, so what basically you're looking for raised ICP signs. So first thing that you can see is a diastolic blunting. So what happens is in the middle cerebral artery, when there is an increased intracranial pressure, what happens is there is no diastolic flow is stopped. Diastolic flow, like in all organs, the diastolic flow is affected. So you have a diastolic blunting, and once you hyperventilate the patient, give him mannitol, give him 3% normal saline, and sedate, paralyze him, and use all your tiers of ICP control, tier 1, tier 2, and subsequently you'll see a improvement in the flow of patterns, and you'll get back your diastolic flows. So it is very useful in subarachnoid hemorrhage and traumatic brain injuries, and correlates with your invasive ICP monitors, especially in hepatic encephalopathy. And it requires training. It is a little bit tougher than your optic nerve sheet diameter. And once you learn it for life. It is with you, provided you do it often. So pupillometry is again very important. Pupillometry, something that's for neurosurgeons, reactivity index, and place it in, especially if you're having skull-based fractures. Again, you might have a lot of blood in the external ear canal, and there are grade having a back, when you're having other external or neurointensive MRIs and CTs, they have their place. Not again and again, once in a day or twice in a day. Bedside, you can use it in the OT, you can use it in the ICU. So it will give you continuous, cerebral oxygenation index, and it's very ideal method of non-invasive tissue perfusion of the brain, non-invasive method to analyze the tissue perfusion of the brain. So optic nerve sheath diameter and TCD are most validated. So MRI, CT have their advantages of high specificity, but again, you have the problems with moving the patient again and again. So just for example, we take one 30-year-old male, GCS6, CT shows diffuse edema, optic nerve sheath diameter is more than 6 millimeters. So the cutoff is 5.5 to 5.7. There's one beautiful article in Nature. So they measure the optic nerve sheath diameter of fit normal Koreans, okay, South Korean patients, and normal optic nerve sheath diameter is 5.5 to 5.7. So anything about millimeters, the ICP is increased. So please remember this in the exam. Okay, so once you give the hyperosmolar therapy, you repeat the ONSD and it might come wrong. Okay, so that is the gist of the slide. On limitations, no universal cutoffs for optic nerve sheath diameter. There's a paper in Nature that was published in April 2025 measuring the normal optic nerve sheath diameter. Okay, so it is measuring 500 normal Koreans, South Koreans optic nerve sheath diameter. So as more studies like that come out in various populations like Indians, like Americans, we will have a proper cutoff levels. But currently it is 5.5 to 5.7 millimeters. Okay, there is some intraoper variability. You can reduce the intraoper variability with practice. So future directions, now many of the ultrasounds are giving AI enhanced. Even if you don't get a proper window for the optic nerve sheath diameter, it will give you a vague corrections. Okay, and there are nowadays portable wearable ICP devices. They are being used by some centers in Japan and Italy, and integration of this optic nerve sheath diameter with other data. For example, you can integrate it with your Codman's catheter, your invasive methods, and take a decision. Okay, to summarize on non-invasive ICP monitoring, non-invasive ICP monitoring complements the invasive monitoring, and sometimes you have to do both. Okay, sometimes optic nerve sheath diameter may be showing some odd reading. I mean, clinically the patient is stable, but optic nerve sheath diameter is showing a higher diameter. There are many other factors which can affect it. So always you correlate with other things like your clinical examination. You correlate your optic nerve sheath diameter with your clinical examination, with your GCS assessments, and use it as a combined index. So thank you. Okay, so now we are going to the second topic. Okay, yeah. The second topic is hypoxic brain injury.
Just a minute. Sorry to interrupt you. We'll and then Dr. Sindhu will present after three topics of yours. And please stick on to time.
Well noted, madam. I crossed by 1 minute.
3 minutes.
Okay, thank you. Got it. Yes, I'll time it now. Okay, 18. Okay, so next topic is hypoxic brain injury. And hypoxic brain injury is one of the most common event that you come across in ICU every day, and most repeated topic in DRNB exams and DM exams also. So both in practical and theory. So basically, hypoxic brain injury is due to reduced cerebral oxygen delivery. So the normal brain oxygen requirement is 50 to 60 ml of oxygen. Okay, 50 to 60 ml of oxygen per minute. So total body oxygen requirement is 250 ml per minute. Almost 60 to 80 ml the brain will only take. Okay, so anything below 80 ml, the brain starts showing hypoxic tissues. First reversible, then irreversible. So the major ICU issues we see cardiac arrest and trauma, respiratory failure, hypoxemia, ARDS, or especially cardiac arrest with prolonged return of spontaneous circulation. You tend to see hypoxic brain injuries. Okay, the pathophysiology is excitotoxicity, mitochondrial dysfunction, and apoptosis. And morbidity is the main problem. Mortality is also the problem. Morbidity, as in, it will increase the ICU length of stay, hospital length of stay, and other length of stay related issues. Okay, so the primary energy failure and ATP depletion is the most common pathophysiology. So there are three phases of the hypoxic brain injury. So in the first phase, what happens is there is primary energy failure, ATP depletion. When the ATP depletion happens, what happens is you tend to get the cell membrane dysfunction and the cells started swelling up. So there is a short interval, it will become irreversible injury. So there is a latent fence, is a short window, and in this short window, you do recovery interventions that by like securing the airway, improving the cerebral perfusion pressure. If you do all this, you will be able to reverse the brain damage. But if the hypoxia or if the hypotension, hypoperfusion persists, so what are the clinical features? For example, in hypoxic injury, so or it might be less than 5, less than 6. There might be and EEG monitoring also shows a hypoactivity, and in neonates there is something called Sarnath staging. And if you do an MRI, actually MRI is the diagnostic modality of choice to confirm hypoxic injury, but we're not going to use it in the first 24 hours. It's after the 48 hours window you get a characteristic signs. It is for neuroprognostication after cardiac arrest. So again, biomarkers are coming up in a huge way. Neuron specific enolase, S100B and all that. But again, the most practical way is clinical assessment and imaging. So prevention is key in general ICU care, hypoxic brain injury, airway breathing circulation, maintaining normoxia, normocapnia, and maintaining optimal cerebral perfusion pressure. Cerebral perfusion pressure is mean arterial pressure minus intracranial pressure, and secondary injury prevention factors like fever prevention. Fever, every 1 degree increase in temperature increases the cerebral metabolic requirement by 20x. So always focus on normothermia at least after cardiac arrest. Prompt seizure detection and treatment is also important because a seizing neuron consumes more oxygen. Okay, so currently the dictum is to management of hypoxic brain injury, maintain euthermia 33 to 36 degrees. There is the Eurotherm trial 1 and Eurotherm 2 trials. Please go through them. And basically what you're doing is you're reducing metabolism, inflammation, and apoptosis. Okay, and pharmacological neuroprotection. So in hypoxic ischemic encephalopathy prevention, whatever pharmaceutical methods you are giving, you're reducing the CMRO2, cerebral metabolic requirement of oxygen, thereby tilting the supply demand mismatch back into the line. So when there is more, you're reducing the demand basically. So the supply, if it is reduced, it will compensate. And multimodal monitoring is very important in hypoxic ischemic encephalopathy, especially continuous EEG, so that if you detect non-convulsive status epilepticals and CSE, you can quickly give drugs and reduce the seizures. Okay, especially when you paralyze the patient, you don't know whether the patient is seizing or not. So the brain might be seizing inside and the patient might be paralyzed outside. So always EEG is very important. So prognosis, especially after prolonged CPR and prolonged CPR, as in more than 8 minutes to 10 minutes CPR, especially conventional CPR, if the quality is also not adequate, more than 50% mortality. So that is the thing. You have to reduce the downtime. You have to prevent cardiac arrest if possible. And always remember the American Heart Association chain of survival, early detection to prevent cardiac arrest. So prevention is better than cure. So there is this article, I want you to go through it, the flare motor sign. So it is published in 2025, 2 months back. So new changes in MRI brain following hypoxic ischemic injury. I'm going to send the link. Okay, the future direction again, you're having novel treatments like melatonin, hypothermia, and erythropoietin. So if they ask you in paper 4 the role of melatonin, hypothermia, and erythropoietin in hypoxic ischemic encephalopathy, you'll be able to write. Okay, so there is role of melatonin, it is proven. There's role of hypothermia and EPO. I'm going to read the articles. So conclude, HBA is a major ICU challenge with high morbidity. So we're going to the next topic. Dr. Rama ma'am, shall I go to the next topic?
Yeah. Please go. Well said.
Yeah.
Any hypoxic injury, almost everything you have covered, and that too in time. Nice of you. We'll go to the next topic.
Yes. So This again, multiple times they have been repeated in paper 2, paper 3 of DRNB, and in DM also they have repeated multiple times, refractory status epilepticus. So the first thing I want all of you to do, if you get this question, is write the definition properly. Write the definition probably. Definition is not my definition or someone else's definition. It is the ILAE definition, International League Against Epilepsy definition. Okay, so the definition, please take photo of this slide. Definitions are very important in the exam. They will read your definitions. So refractory status epilepticus, there are 2-3 things that we need to clear here. Status epilepticus is seizure activity more than 5 minutes or recurrent seizures without any subsiding. Okay, and failure to respond. Refractory status epilepticus is failure to respond to one benzodiazepine and one second line agent. One second line agent. So there are first line, second line agents. So second line agents include eptoin, phosphatoin, anything, and failure to respond to benzodiazepine, that is lorazepam. So refractory status epilepticus as per ILAE is not defined by duration, but rather as status epilepticus that does not see this administration of 2 anti-seizure medications. So one is an intravenous benzodiazepine and other is a longer acting second line medication, anti-seizure medication. So RSE occurs approximately in 1/4 of status epilepticus cases and has high mortality and morbidity. Okay, and just covering the definition of super refractory status epilepticus, the seizures persist more than 24 hours despite anesthetics. So the reference is in the bottom of the slide. It is Farooq S. Joseph 2025 in Turkish Journal of Intensive Care. So the pathophysiology is failure of GABAergic inhibition. So what happens is, as the seizure duration increases, the GABA receptors are irreversibly modulated so that they become hyporesponsive to the GABAergic phenomenon. So all your benzodiazepine. So how does benzodiazepine act? It acts by again increasing the GABAergic activity. So what happens is, as the seizure increases, duration increases from the index minute, it becomes more refractory. The neurocerebral cortex undergoes irreversible and reversible changes that make it hypo-responsive to the anti-seizure medication itself. So it is given a very interesting way in Irwin and Rippe. So you can go and read it. Okay, please read textbook before you go sit for the exam. Irwin and Rippe. Yeah. So excessive glutamate excitotoxicity, blood-brain barrier dysfunction, and neuroinflammation, and receptor trafficking and ion channel changes. So these are irreversible changes that I was talking about. So clinical spectrum: convulsive, non-convulsive, and super refractory status epilepticus. Etiologies might be metabolic, drug withdrawal, stroke, infection. So especially in patients with known epileptic syndromes, a simple discontinuation of the drug, simple stopping of the anti-epileptic therapy can trigger all the refractory status epilepticus. Or unfortunately, some epileptic patients, if they develop some meningitis or any other road traffic accident or trauma, they are even more susceptible than the general public. Okay, so evaluation is continuous EEG monitoring, neuro monitoring, and CSF analysis, for example, to know any meningitis or any other issues. Early identification of the etiology is critical because you are treating the symptom. You are using your first line, second line, third line anti-epileptic drugs to treat the symptom, but you have to treat the cause. For example, if it's a cortical hematoma, you have to evacuate the hematoma. Okay, and if it is a meningitis, you have to treat the meningitis, or for that matter, encephalitis. So stepwise approach is very important. Many times they ask in the exam. So first thing, airway breathing circulation and IV lorazepam. IV lorazepam, and 4 milligrams. And you can use it as 0.04 mg to 0.06 mg per kg body weight. And second line are phosphatocodeine, valproate, and levetiracetam. And for refractory status epilepticus, you use anesthetics, midazolam, propofol, and phenobarbital. What I want to advise all my critical care colleagues is never what do you call this inhibit yourself from using the anesthetics. We are trained in anesthetics, so we are more comfortable in using them to terminate the seizure. Okay, so super refractory status epilepticus, you can use ketamine and other immunotherapy. Okay, so this is the flow chart that we want to follow in status epilepticus. First thing is your first line drugs, lorazepam, and then you give a longer acting agent. Lorazepam will take care till maybe 15 to 25 minutes. Anti-epileptic action, peak anti-epileptic action. After that, you want to give a longer drug. Okay, so you don't want the agent. So novel adjunctive therapy is, for example, for refractory status epilepticus includes IVIG, plasmapheresis, and all that, and they are still under investigation. For example, if your first line, second line, third line drugs also fail, you might have to use this. Or if they have partially worked and patient continues to have secondary episodes. So mortality is 20 to 40% depending on the etiology. Again, when you're talking about RSC, we're talking about the symptoms. We are talking about a clinical sign. There might be a primary pathology like traumatic brain injury or meningitis. So it depends upon the etiology. Okay. So this is the flow chart. I want all of you to remember. The first line drugs, again repeating, IV lorazepam, 0.1 milligram per kg, 0.08 to 0.1 milligram per kg, maximum 4 mg. Then you have the second line drugs, fosmantoin, valproate, Livera, and phenobarbital. So fosmantoin, everyone is comfortable, but the thing you need to think about fosmantoin is give it over 15 minutes. Don't give it as a bolus. It can cause bradycardias. And refractory status epilepticus, you're using propofol, midazolam. So while using all these anesthetic drugs, you have to make sure that mean arterial pressure is maintained because they all have the cardio inhibitory effect. And super refractory status epilepticus, you can use ketamine. So this is one paper that was published in September 4, 2025. So super refractory status epilepticus and status epilepticus diagnosis and management. I will just leave the paper before you. Okay, so just go through it before sitting for the exam. Thank you so much. Over to you, madam.
Dr. Srihari is a critical care consultant at Apollo Hospitals, Visakhapatnam, is going to present his topics.
Okay, I'm stop sharing my screen.
Hello. Am I audible, ma'am?
Yes,
Okay.
but your presentation is not showing on screen, sir.
Is it visible now, ma'am?
No, sir, it's still not visible. You have to open the presentation fully and share the entire screen, which you have done already. Yes, sir. Now, if you can do full screen, yes.
Full screen.
Yes, that one, sir.
Okay.
Yeah, you're good to go, sir. Perfect. Please continue. Please continue.
Okay. Good evening, everybody. Today I'll be presenting about the topic acute bacterial meningitis. This is important both in the theory wise as well as in the practical session. Next slide.
My topic right now is continuation of the three topics now. Management of subarachnoid hemorrhage. Again, very important in the exam, and clinically also.
So, full screen, please.
Yeah, yes. From current slide, yes. Full screen now. So again, very important topic clinically and in the exam as well. So recurrent repeats in the questions and also in the practicals also. And there's a lot of neurocritical care content in the subarachnoid hemorrhage and in Viva was also. So let's go to it directly. So our learning objectives will be understand the pathophysiology of aneurysmal SOH in brief, review ICU management before securing the aneurysm and after securing the aneurysm. So there are two phases in the ICU, before, after securing the aneurysm, and discuss post-coiling clipping, neurocritical care, examine prevention and treatment of vasospasm and delayed cerebral ischemia, very important, and explore systemic complications and long-term care. So epidemiology, 6 to 9 in 1 lakh people years worldwide, and it can happen in anyone from 18-year-old to 80-year-old. It can happen in anyone. Many a times counseling will be a problem in these cases. They will tell इतने छोटे उम्र में कैसे हो गया bleeding, brain stroke कैसे हो गया. So you will have to counsel them. It's a counseling challenge. So risk factors can be hypertension, smoking, genetic syndromes, especially when it is genetic syndromes, counseling. And better detection, but high morbidity persists. Nowadays, we are having CT angiograms, prophylactic CT angiogram, prophylactic MR angiograms, preventive packages offered by neurologists. So what happens exactly? Pathophysiology. So when there is an aneurysm rupture, there is hemorrhage in the subarachnoid space. So blood in the subarachnoid space. That will increase the ICP. It will increase the intracranial pressure and reduce the cerebral perfusion pressure. So what happens? There is early brain injury. There is oxidative stress, apoptosis, inflammation, and there is secondary injuries that can happen. So it can be vasospasm, delayed cerebral ischemia, and seizure activities. Okay, so in the chronological order, three things can happen: rebleeding, hydrocephalus, vasospasm. In this order, the complications of subarachnoid hemorrhage. So the blood breakdown products in the subarachnoid space are again triggers. The oxyhemoglobin are irritants for the brain. Seizures can happen. So it can trigger a lot of phenomenon which can cause secondary brain injury as well. The primary problem is done, but the secondary brain injury can happen. There can be takasubocardiomyopathy. There can be neurogenic pulmonary edema. There can be a reduced cardiac output state. So it is a systemic disease. Subarachnoid hemorrhage is not confined to your cerebral circulation. It's a systemic disease. When the cardiac output reduces, again you have reduced cerebral perfusion, and ICP will be increased. So multiple things can happen. So very important for the neurocritical care physician. Okay, we use the Hunt and Hess and modified Fisher grading. Okay, for classifying the severity of the subarachnoid hemorrhage. It is available in all textbooks. So as the Hunt and Hess increases and World Federation of Neurosurgical grading increases, the outcomes also worsen. Okay. And for example, new prognostic tools are including the frailty of the patient. For example, if the patient is older, you'll have multiple comorbidities, again, lung pathologies, heart pathologies, again, worse prognosis. So initial ICU management, again, airway breathing circulation, airway intubated GCS less than 8, maintain normoxia, normocapnia. Hypercapnia increases, causes cerebral vasodilation, increases ICP, and maintain euvolemia and cerebral perfusion pressure. And analgesia is very important because rebleeding is very common in the first 24 hours. Even if you are putting an IV cannula or a central line for a patient with SAH, give local, no pain. So pain increases the blood pressure and triggers a rebleeding. So blood pressure control, pre-securing. Many most commonly asked question is before the securing aneurysm, by coiling or clipping, what you will do, after securing, what you will do. So preventing rebleeding is the goal before securing it. Common target systolic blood pressure less than 160 or less than 160 to prevent the rebleeding, and use short-acting agents like nicardipine, labetalol. Labetalol is intermediate again. You can use it to control the blood pressure. Avoid hypotension versus the cerebral ischemia. Okay, and rebleeding is highest in the first 24 hours after the ictus. Okay, so antifibrinolytics, thromboxane reduce bleeding but increase ischemia, so we don't use it routinely. Not recommended in 2025. So I have done literature review as per 2025, not recommended. I will just put the evidence at the end of the presentation. I'll give it to you as well. Focus on early aneurysm securing. Okay, so don't use tranexamic acid to stop the bleeding and all that. Focus on securing the aneurysm either by coiling or clipping. Okay, so acute hydrocephalus is also very much common. So especially if there's an intraventricular extension of the blood, and placement of the EVD is paramount. And keep the ICP below 20 and keep the cerebral perfusion pressure more than 60. Arterial line is a must. And continuous intermittent drainage of the catheter if required. If there is intraventricular catheter put in, you need to drain it to maintain the cerebral perfusion pressure. So maintain normothermia, avoid fever. Fever is common, especially when you are having subarachnoid. Hours, less than 12 hours. So if you coil the aneurysm, it should be within less than 24 hours. So that will reduce the chance of rebleeding, reduce the ICU duration of stay also. Stabilize the airway and blood pressure electrolytes as discussed before. And as endovascular coiling has been shown to reduce the mortality when compared to clipping. Coil. Okay. Clipping done where you don't have interventional for doing your coiling. So coiling is the procedure of choice. After the coiling, during the coiling, you need to maintain the mean arterial pressure And after coiling, avoid hypotension, maintain cerebral perfusion at 60 to 70. Euvolemia is the goal. And previously in old textbook, they used to say triple H treatment, hypervolemia, hypertension, and you don't need to do all that. Maintain normovolemia and avoid hypotension, and monitor for vasospasm. Okay, oral nimodipine 60 mg 4th hourly is the standard of care, and some neuroradiologists advocates intra-arterial nimodipine also. Nimodipine is a selective cerebral vasodilator. Monitoring for vasospasm and delayed cerebral ischemia is very important. They will develop new onset focal neurological deficits, and you should not wait until he develops a focal neurological deficit. You should keep doing the transcranial Doppler. Transcranial Doppler is very important bedside modality for detecting vasospasm. So for what you do for vasospasm, you start nimodipine, verapamil, nicardipine, and sometimes you can start your noradrenaline, increase the blood pressure as well. And in refractory cases, they have used again interventional radiological procedures like balloon angioplasty, especially if in the proximal, M1 vasospasm. And sometimes ICP increases and there might be severe edema. So in that, mannitol, 3% normal saline are first line. So decompressive craniotomy in refractory ICP cases. No role of corticosteroids. So as discussed, it's a multi-system disease from from the onset of ictus, many things might happen, aspiration pneumonia, and that might lead to all their consequences, downhill consequences. And DVT is a known complication. Early enteral nutrition, stress ulcers might occur. Glycemic control is very important. Avoid hypo or hyperglycemia. So prevent all the secondary neurological injury factors like hypoxia, hypotension, and sepsis, fevers. So anything which can cause a secondary neurological injury, you should avoid. Nutrition is very important, and glycemic control. Hyperglycemia Okay, so take home points again: early coiling and nimodipine, and maintain the mean arterial pressure, avoid hypoxia, avoid hypercarbia, avoid hypotension. So there's a beautiful table in the ICU manual. Okay, so avoid all the secondary brain injuries. So these are the references I will give away, and recent 2025 references also have taken. Okay, so you want me to continue with the next presentation, or Srihari, you would like to take over?
Please go ahead, Dharani.
Okay, so next important topic is traumatic brain injury. In the slide itself, there is an 2025 update that is there in the slide. So that is the ATLS 11th edition is around the corner. By the time you all go for a practical, the ATLS 11th edition will be printed out and it will be circulating. So they'll ask you what is the latest, protocol for ATLS. So in the 11th edition, it is XABCDE. So previously it was ABCDE, Abhi XABCDE. Okay, so we'll learn what it is and what is traumatic brain injury. Okay, so XABCD again, control of exsanguination, then airway, breathing, circulation, disability, exposure. So in all the last 10 editions of ATLS, it was ABCDE. Now X is ahead of airway. Exsanguination control, identify major bleeding and apply pressure. Then go for airway, breathing, circulation, disability, exposure. Okay. So in polytrauma, exsanguination control is key. So airway with cervical spine protection. So always A with cervical spine protection. And breathing, again, in traumatic brain injury, maintain SpO2 above 94, avoid hypercarbia. Hypercarbia causes cerebral vasodilatation, increase ICP. Avoid high PEEP in traumatic brain injury, especially prior to decompression craniotomy or something like that. If you give high PEEP, high volumes, intrathoracic pressure increases, intracranial pressure increases. So the abdomen the thorax and the cranial vault all are in continuum. Any pressure increase in one cavity will increase in other. So in the trauma case, the patient might have bleeding from multiple places. He might be hypovolemic, hypotensive. So maintaining the cerebral perfusion pressure is important, and documenting the first GCS before intubating the patient. So many a times, no, there is a conflict. Sometimes, the patient is intubated in the ER. He comes to the ICU. The neurosurgeon will come. Are pehle GCS kitna tha? Abhi GCS kitna hai? They'll ask you that. But the problem is you have sedated the patient. You have taken care of the airway breathing circulation. You have intubated the patient. You're not able to tell what was the GCS before intubation. So proper handover from the emergency room is very important. So pre-induction GCS is very important for taking a decision on any active neurosurgical intervention. So exposure and environmental control, again, it's very important to reduce the secondary injury. So if the patient is bleeding from elsewhere, you're going into hypovolemia, hypotension, that will worsen your brain factor, brain tissue perfusion. So the 5 H's you have to avoid in traumatic brain injury. Avoid hypoxia, avoid hypotension, avoid fever, avoid hyperglycemia, avoid hyponatremia, and maintain normovolemia, normal thermia. Correct all electrolyte abnormalities, sodium, potassium, magnesium, and calcium. Each can affect. So if there's hypokalemia, there can be arrhythmias that will reduce the cerebral perfusion pressure. So you have to correct each things. Okay, hypocalcemia will cause seizures. So hypocalcemia is very much possible in trauma because you're giving a lot of blood units. If you're giving a lot of blood, hypocalcemia might occur. Okay, so be very careful. Avoid hyperglycemia. So blood sugars more than 180. So in traumatic brain injury, again, ICP monitoring is very important. As we discussed, there are non-invasive and invasive methods. Parenchymal probes, invasive methods are indicated when you have the support and you have the equipment for monitoring the continuous waveform analysis. So any monitoring technique will not improve the prognosis. A monitoring technique will improve the prognosis only when you act on it. So if you have the Codman catheter, you can monitor the ICP, you know the waveforms of the ICP, and please learn the waveforms of the ICP. I'm going to tell you briefly in the last. So this is the most common Viva question, and in theory they are expecting you to write this. Okay, ICP management, tiers of ICP management, tier 0, tier 1, tier 2, tier 3. So tier 0 is the basic care for any traumatic brain injury patient. Head up, and if the patient is having pain, for example, he's having a fractured femur or fractured ribs, you have to give some analgesia and denote the GCS before giving analgesia and sedation. And I stress on analgesia rather than sedation. When you take care of the pain, automatically the patient might calm down. And hyperosmolar therapy, and you can give mannitol, hypertonic saline, and neuromuscular blockade. Again, it's a tier 2 for reducing the intracranial pressure, and you can hyperventilate and optimize sedation. See, hyperventilation can be only done transiently. You're driving out the carbon dioxide, thereby causing cerebral vasospasm and reducing the cerebral blood flow. So hyperventilation is a rescue method of reduction of ICP, especially when you ventilated the patient, it's under your control. And tier 3 measures like barbiturates, hypothermia, and decompressive craniotomy. So tiers of ICP management, very important. Tier 0, 1, 2, 3. And the standard targets, again, we're repeating: cerebral perfusion pressure of 60 to 70. Avoid cerebral perfusion pressure less than 50. And avoid cerebral perfusion pressure more than 100. If you have hypertension also, again, problem, cerebral edema. So auto-regulation is very important. Some patients are pre-existing hypertensives and their cerebral perfusion, is shifted to the right. So you have to be very important. So please read the cerebral perfusion graphs before you go to the exam. Osmotherapy, mannitol, hypertonic saline, and especially in trauma, people prefer hypertonic saline. I'll tell you why. Because mannitol, again, will cause diuresis. It can cause hypovolemia and all kinds of problems. So hypertonic saline is the probable drug of choice for traumatic brain injury, ICP reduction. Okay, so there is the ICP repeated hundreds of, and you will advise a decompressive craniotomy. They'll ask you that. Okay, so in the rescue ICP trial, what they do is decompression craniotomy reduce mortality, but more survive the life. But the patient remains, on the bed in a morbid state. So the Glasgow outcome scale is poor. The patient is not functional, is not returning to his baseline status, but they managed to save the life. Okay, so that is the outcome of the trial. But these days, evidence based. So if the patient wants to go for a decompressive craniotomy, irrespective of the outcome, to save the life, you have to go for it. So when it is indicated when the ICP is refractory to conventional measures and it's more than 25. Early versus late again remains a debate, and early reduces the mortality and puts more survivors. And survivor doesn't mean he is back to his baseline status. Essential to involve family in decision making in these things. So seizures, again, seizures is very important control. Seizure control, especially in cortical bleed. So when there's a cortical bleed, it keeps irritating the neurons, and you'll have seizures. So seizure control is very important in traumatic brain injury. There is no role of prophylactic antiepileptics. There's no role of prophylactic antiepileptics. Examiner might ask you, okay, the patient is having traumatic brain injury and cortical hematoma, and he has no seizure. Will you start antiepileptics prophylactically? Okay, in practice, you might start. In neurologist, neurosurgeon might start, but as per evidence, if there's no seizure activity, either clinical or in EEG, you don't need to start a prophylactic antiepileptic. Okay, avoid fever and avoid all the other 5 factors we have discussed, secondary brain injury factors. Okay, and the traumatic brain injury, what happens is there are 3 hits in trauma: first hit, second hit, third hit. So the second hit is your all infections, all your resuscitation, trolley, taco, surgical procedure related complications, iatrogenic complications, and the third hit is the sepsis. So even if you do a good job with the decompressive craniotomy and early neurosurgical care, you have to equally maintain. The patient is going to stay, for especially neurosurgical cases, they're going to stay in the ICU for a couple of days. So you have to take care of all your fast BD bundles. Nutrition is very important. They're hypercatabolic, trauma patients. Thromboprophylaxis. Thromboprophylaxis is very important. Psychologically, we put it at the back of the mind. It takes a back seat when the patient is bleeding. For example, he is having abdominal trauma, hemoperitoneuum, and all that. You don't want to give anticoagulant even after the surgery. But you have to go for at least mechanical therapy to prevent DVT. Compression stockings, sequential and dynamic both. Balance risk of hemorrhage and thrombosis. So future directions, more ICP monitoring, more PBTO to tissue pressure monitoring are coming up, but still yet to be proven. Biomarkers like GUFAP and UCH for prognostication in traumatic brain injury are coming up, and AI and ML phenotyping they're doing. I'm going to leave the links. So it is in base of the slide, Frontiers in Neurological Care 2025, Emerging TBI Reviews. So it is in the bottom of the slide. I'm going to leave that paper to you. So in paper 3, they might ask you. So always read and go, read and go, read and go. So these are the references. You can take a snapshot and you can read. Thank you so much. So, Rama madam, I'll let
Just,
you. I'll let
because
Hari go
1
ahead.
hour is over, Dharani, we shall start Sindhu's, and probably time permits or Sudeshna permits, we shall go with the last topic in the last. Is it okay?
Fine, ma'am. Yeah.
Whatever is okay with you, ma'am. Sure. You have to stop sharing, sir. Then only Dr. Sindhu will be able to share.
Yeah. I stopped. I stopped.
Yeah. Dr. Sindhu, you have to unmute yourself.
Dr. Sindhu is working as a critical care consultant at Apollo Hospitals, Visakhapatnam.
If you can kindly do a full screen now. Yes, that button.
Okay.
Perfect. Yes, ma'am, you are.
So the next question for discussion is about Guillain-Barré syndrome. GBS is the leading cause of acute facet tetraplegia worldwide, with an incidence of approximately 1 to 2 cases per 1 lakh inhabitants per year. This acute polyneuropathy in GBS is often triggered with immune response to an antecedent infection or other event that cross-reacts with shared epitomes on peripheral nerve. The triggering events can be most of the times Campylobacter jejuni, which is the frequent infectious agent which triggers GBS. The other are bacterial triggers, viral triggers, post-vaccination immunotherapies, and some chemotherapy drugs also known to cause triggering of GBS. The pathophysiology, the range and extent of pathological changes depend on the clinical forms of GBS. It can be either demyelinating form or axonal loss. In demyelinating forms like AADP and MFS, Miller-Fisher syndrome, there is a focal inflammatory response that develops against the myelin-producing Schwann cells or the peripheral myelin, in which the antibodies targeting the myelin proteins and structures at the nodes of Ranvier will be produced, which will cause demyelination and thereby blocks the saltatory conduction along the nerve. In axonal loss, in axonal variants, there will be antibodies targeting the gangliosides at the nodes of Ranvier, which will lead to axonal involvement with conduction blockade and may progress to axonal degeneration. The clinical presentation, patients typically present with rapidly progressing ascending symmetrical sensory motor deficit, evolves through 3 distinct phases: the progression phase, plateau phase, and the recovery phase. In its classic form, patients often first experience sensory disturbances like paresthesia, ataxia, and radicular pain in the lower limbs, which gradually ascends to the upper limbs, followed by motor deficits. So initially, tendon reflexes may be present, but gradually they will decrease and eventually disappear. And some patients may experience severe lumbar pain and other radicular pains. At the peak of the disease, involvement of facial, pharyngeal, laryngeal muscles can be seen along with the involvement of respiratory muscles. And some patients may present with dysautonomia, leading to cardiac arrhythmias, blood pressure instabilities, urinary retention, and functional illness. So what are the variant forms of GBS? The common forms are AADP, which is the most common form of GBS, representing around 85 to 90% of the cases. And MAN variant, acute motor axonal neuropathy, selective involvement of motor nerves will be seen. In MSM variant, which is a more severe form of MON, both sensory and motor fibers are affected, and which causes delayed or incomplete recovery. The other GQ1B syndromes are Miller-Fisher syndrome, characterized by ophthalmoplegia, ataxia, areflexia, and Bickerstaff brainstem encephalitis, in which patients present with encephalopathy along with ophthalmoplegia and ataxia. Then pharyngeal cervical brachial weakness, and the other rare varieties are paraparesis, acute pan-dysautonomia, pure sensory GBS, facial diplegia and distal limb paresthesias, and acute bulbar palsy. So how do you diagnose GBS? Diagnosis of GBS is primarily clinical, with lumbar puncture and ENMG used to confirm the diagnosis and exclude other differential diagnoses. Antiganglioside antibodies and infectious disease serologies can also aid in the diagnosis. And in patients with asymmetrical presentation and with very acute onset, a cerebral or spinal MRI may be necessary to rule out other etiologies. Brighton criteria is proposed, which includes the clinical features, additional clinical features, CSF analysis, and nerve conduction studies. If all of these features are present, there is highest level of diagnostic certainty for GBS as per the Brighton collaboration. Coming to the lumbar puncture, albino-cytological dissociation is the classical form, a classical thing which is seen in GBS, which is characterized by elevated protein levels with fewer than 10 cells per ml in the CSF analysis. And this albino-cytological dissociation may be absent in up to 50% of the cases during first week of symptoms and in 10 to 30% of the cases during second week. Lumbar puncture is usually crucial when there is bilateral facial palsy or cutaneous vesicular eruptions to rule out Lyme disease or varicella zoster infection. Coming to the electroneurommyogram, like lumbar puncture, ENMG can initially yield normal results if performed very early after the symptom onset. And the diagnostic features in AADP are increased distal motor latencies, decreased conduction velocities along with conduction blocks and temporal dispersion, and needle EMG of the muscles may show reduced recruitment or denervation. And prolonged or absent F waves and absent H reflexes are also seen as earliest findings. In MR variant, reduced amplitudes of motor waves will be seen. In MSAR, reduced amplitudes in both motor and sensory waves will be seen. So these are the differential diagnosis of GBS based on the site of involvement from brain to cerebral parenchyma to peripheral muscles, neuromuscular junction, and peripheral nervous system. So coming to the management, the three major management issues in the GBS are the choice of immunotherapy, either IVIG or plasma exchange, airway management, and autonomic dysfunction. In patients who present within the first 2 to 4 weeks from symptom onset and who are unable to walk unaided, with the GBS disability grading of 3 or more, needs to be treated with either IVIG or plasma exchange as soon as possible. IVIG at a dose of 2 gram per kg, that is a 0.4 gram per kg per day divided in 5 days, should be given to all the patients. And the clinical response is noticeable within 3 to 7 days. Second course of IVIG is required only in case of treatment-related fluctuations. And coming to the plasmapheresis, 4 to 5 plasma exchanges over 1 to 2 weeks with a total exchange volume of 12 to 15 liters is the recommended dose. And the replacement solutes can be either 5% albumin or FFP if there is altered blood coagulation. There is no significant difference in the treatment efficacy demonstrated between both IVIG and plasma exchange in many of the RCTs conducted. The European Academy of Neurology and Peripheral Nerve Society guidelines on GBS recommends no preference for the treatment of either IVIG or plasma exchange. So, who are the patients that need to be kept in ICU for the monitoring? For this, modified EGRI score was proposed, which contains 4 components: the bulbar weakness, time from weakness onset to admission in the hospital, and neck flexion MRC score of 0 to 5, and bilateral hip flexion MRC score of 0 to 10. So patients with a modified EGRI score of more than 25 to 32, and patients with important risk factors at presentation, these are the 6 risk factors, and any more than 4 of the 6 risk factors are positive. And clinical assessment, if any of the clinical assessment signs are positive, these patients come under high risk and they have to be kept in ICU, and the patients with moderate risk also should be kept in ICU. And coming to the airway management, the important thing is assessing the need for impending respiratory failure like loss of airway protection, bulbar weakness, difficulty in talking, swallowing, pooling of secretions, and quadriplegia, inability to lift head off the bed, single breath count of less than 20, and signs of respiratory distress, and the 20-30-40 rule. Vital capacity of less than 20 ml per kg or less than 60% of the predicted falling in the vital capacity, and MEP of less than 30 centimeters of water, MEP of less than 40 centimeters of water. These are the indications for immediate intubation and mechanical ventilation for securing the airway in patients with GBS. So coming to the management of dysautonomia, in patients with abdominal distension and aerodynamic ileus, NG tube suctioning and laxatives for constipation should be given, and bladder catheterization for urinary retention, and hypertension should be treated with antihypertensives and avoid beta blockers. Hypertension should be treated with IV fluids, and bradyarrhythmias may require atropine and sometimes temporary pacing. Coming to the general ICU management, we should give DVT prophylaxis to all the patients, and for the pain control, gabapentin, pregabalin, and tricyclic antidepressants are needed. And effective communication and psychological support, early mobilization, and appropriate positioning to prevent contractures, rehabilitation, and physiotherapy are important in the early recovery of the patients. And coming to the timing of tracheostomy, consider tracheostomy in a patient who remains ventilator dependent after 2 weeks and has failed multiple weaning trials. What is the prognosis and long-term outcome? The long-term prognosis is favorable for most of the patients with GBS, and these are the risk factors for poor outcomes. And these are the 2 scores, EGO score and modified EGO score, which can be used at 1 week and at 2 weeks after the admission to predict the patient's prognosis at 6 months. Thank you. These are the references.
Okay. Dharani, anything that you want to add? Dharani? Yeah, you can, Sindhu, you can go ahead with your second presentation, CIPN.
Yes, I'm ready. Yeah, I'm ready. Yes.
No. Dharani, Sindhu is continuing. I just wanted your input for GBS. Anything that you want to add on?
Okay, ma'am. Yeah, so I just wanted to say one thing here. Guillain-Barré syndrome is, especially in theory, they'll expect you to write a lot about Guillain-Barré syndrome. I mean, in the given time. First thing, it is very common. They will focus on one thing, that is when you want to intubate the patient. So Dr. Sindhu has presented very clearly when to intubate. So, your brainstem reflex, your bulbar reflexes are gone, and your respiratory capacity will be gone, ability to cough and, you ventilate. So it is very critical. Sometimes these patients are in the wards. So you'll be called to see these patients in the wards. They'll admit in the ward, they will start IVIG therapy, and IVIG therapy, the patient is not improving, and they'll call you for a consult, whether to shift to ICU or not. So you have to, rely objectively on the bedside assessment to decide when to shift to the ICU, when to intubate the patient. Because majority of the morbidity and mortality that can happen in GBS is because of inadequate respiratory support at the appropriate time. So we have seen cases that have been, that have been not taken care in the evening, that have become hypoxic overnight and develop like cardiac arrest also. And so that is why it's very important. IVIG will give you a, pseudo sense of security. अरे दिया एकदम से ठीक हो जाएगा. No, the IVIG after completing the dose also, the response is rather than slow, I say it is of intermediate improvement. Gradual improvement will be there because neuromodulation and mechanism of immunoglobulin action will take time. So that is one thing I want to get across. That's it, ma'am.
Thank you. So she'll move on with the second topic, critical illness polyneuropathy.
Coming to the next topic, the critical illness polyneuropathy, which is one of the spectrum of the disease, ICU-acquired weakness, which is a syndrome of generalized limb weakness that develops while the patient is critically ill and for which there is no alternative explanation other than the critical illness itself. The spectrum of the disease includes critical illness polyneuropathy, critical illness myopathy, and critical illness neuromyopathy. What are the risk factors? Risk factors are broadly classified into modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are hyperglycemia, parenteral nutrition, and drugs that are commonly being used in ICU, the vasoactive drugs, neuromuscular blockers, corticosteroids, sedatives, and certain antibiotics like aminoglycosides, vancomycin, and polymyxins, and prolonged immobilization. Non-modifiable risk factors are severity of the disease, sepsis and SIRS, multi-organ dysfunction, prolonged mechanical ventilation, high lactate levels, female sex, older age, and premorbid functional status of the patient. So what is the pathophysiology? Critical illness and cytokine production will lead to the three major alterations: the microvascular alteration, which leads to vasodilatation, increased permeability, extravasation of leukocytes and hypoxemia, and the metabolic alteration, which will cause hyperglycemia, catabolic pathway activation, mitochondrial failures, reactive oxygen species production, and the electrical alteration along the nerves, like sodium channel dysfunction and altered calcium homeostasis and cellular inexcitability, which will eventually lead to critical illness polyneuropathy and myopathy. The clinical presentation in CIM is flaccid quadriparesis that may affect the proximal muscles more than the distal muscles and failure to wean from mechanical ventilation. Facial muscle weakness is also relatively common, but extraocular muscle weakness rarely occurs. And there will be no sensory involvement in case of critical illness myopathy. So the patient should at least try mass to painful stimuli even when they are encephalopathic. Deep tendon reflexes may be normal or attenuated. In CIP, the clinical features can overlap with those of CIM, and in many patients with CIP, they require prolonged weaning from mechanical ventilator, and the affected patients manifest a sensory motor polyneuropathy characterized by limb muscle weakness and atrophy, reduced or absent deep tendon reflexes, loss of peripheral sensation to light touch and pinprick, and relative preservation of cranial function. So coming to the diagnosis is based on clinical evaluation of the muscle strength, electrophysiological testing, and muscle biopsy. In muscle biopsy, CIP will show the findings of neurogenic atrophy in the muscle, and CIM will show the presence of myopathy, classical myopathy in muscle biopsy. The clinical evaluation of muscle strength is based on MRC sum score and handheld dynamometry, which assesses the hand grip strength, and the threshold values are less than 11 kg for males and less than 7 kg for females. The MRC sum score, total 12 muscle movements were tested, and the movement tested on each side are arm abduction, flexion at the elbow, wrist extension, hip flexion, extension at the knee, and ankle dorsiflexion. And the score for each movement range from 0 to 5, 0 being no movement and 5 being normal power. A total score is 60, and a score of less than 48 indicates ICU-acquired weakness, and a score of less than 36 indicates severe ICU-acquired weakness. But the difficulties in diagnosing clinically are poor patient communication, altered sensorium in ICU patients, encephalopathy, and presence of limb edema. Coming to the electrophysiological features for the diagnosis of CIP and CIM are compound motor action potentials, amplitude will be decreased in both CIP and CIM, but the duration will be normal in CIP and the tubes. And repetitive nerve stimulation will show absence of decremental response in both of them in contrast to the myasthenia gravis. And direct muscle stimulation will show normal muscle excitability in CIP and reduced muscle excitability in CIM. This is the classical features that can differentiate CIP from CIM. So these are the differential diagnoses that can differentiate the acute generalized weakness syndromes in critically ill patients from brainstem lesions, spinal cord lesions, anterior horn cell syndromes, polyradiculopathies, peripheral nerve disorders, neuromuscular junction disorders, and muscle disorders. Please go through them. And coming to the management options, the management of critical illness polyneuropathy is primarily based on the prevention and treatment of the underlying disease, like early treatment of the sepsis and prevention of developing multi-organ dysfunction syndrome, and avoiding the prescribing drugs certain antibiotics and prolonged use of sedative drugs, as the use of sedative drugs and prolonged immobilization have been associated with increased risk of developing critical illness polyneuropathy. A reduction in sedation and early initiation of mobilization is very important in the management. So optimal rehabilitation strategies with early mobilization and early initiation of physiotherapy from supine to sitting and then to walking, bedside cycle ergometry, and passive mechanical loading are all important in the prevention and management of critical illness polyneuropathy and myopathy. And prevention of blood sugar fluctuation is also one of the important things, and maintain a target blood range in the euglycemic range with 140 to 180 with insulin therapy when required. The other therapies that are proven beneficial in trials that are not proven beneficial in trials despite theoretical benefit are IV immunoglobulins, vitamin C, and vitamin E, the antioxidants. And coming to the nutritional therapy, avoidance of parenteral nutrition is important, as parenteral nutrition has a detrimental effect in development of CIP. And start enteral feeding as soon as possible to prevent muscle wasting, increase amino acid supplementation, and omega-3 fatty acids. The drugs like anabolic steroids, growth hormones, nandrolone, and testosterone have been studied with no side effects in critically ill patients, but they require larger studies to prove the benefit in the management of CIP. Neuromuscular electrical stimulation, because of the poor alertness and cooperation that precludes early active mobilization of ICU patients, neuromuscular electrical stimulation has been suggested as an alternative to the routine physiotherapy. Several small RCTs have been performed in critically ill patients with variable use of frequencies, intensities, and duration of NMES with widely varying outcomes. So, therefore, the effect of NMES therapy further need further investigations for its role in management of CIP. So what are the acute and long-term complications? Short-term complications are increased ICU and hospital mortality, prolonged ICU length of stay and prolonged hospital length of stay, increased hospital cost, and prolonged need of mechanical ventilation, increased risk of extubation failures, increased risk of swallowing disorders like post-extubation dysphagia and ineffective cough. These are the short-term complications. And the long-term complications are increased post-ICU mortality, decreased discharge to home, decreased physical functioning, increased length of rehabilitation stay, and increased discharge to other hospitals or rehabilitation center. So, in evaluation of patients 1 year after ICU discharge, suggested that a myogenic origin, the CIM, had a better prognosis with virtually full recovery as compared with CIP that left 50 to 75% of the patients with persisting muscle weakness and even tetraparesis. And these two are the references. Thank you.
Very well covered, Sindhu. Almost you have covered everything in the toughest, one of the toughest topics and most often asked one. And now we'll move on to Dr. Srihari. He'll be presenting bacterial meningitis. And what's the other topic, Srihari? Breaking bad news. Anything, Dharani?
Yeah, well covered. Only thing is, critical illness neuropathy myopathy will come as a discussion in practical in all long cases. If any, in all ICU related cases, they will like to touch on critical illness neuropathy myopathy. If not theory, they'll definitely ask you practical viva, therapy, management, and all that.
So we can't hear you. If you can increase the speaker sound, sir.
Hello. Is it audible?
Now it is. Yes, sir. We are audible. You're audible. Can you hear us also?
Today the topic of presentation would be acute bacterial meningitis.
Please continue. Is the slides not moving? Then do you want us to share the slides? Should we share the slides, ma'am?
Yeah, it's from Sindhu.
Yeah.
Please accept that.
Yeah, sure.
First accept, Sindhu.
Ma'am, what do you mean by accept? You can just, yeah, absolutely. Perfect.
Any issues?
Yeah, we are starting. Sorry for it.
Any issues, sir?
Dharani started.
Yeah, please go ahead.
So, I will cover this topic with the following headings.
Yeah, Dr. Srihari, please go ahead.
Yes.
We have no issues.
I will cover this topic under the following headings. So, the acute bacterial meningitis, inflammation of pia and arachnoid meningitis that covers the brain and spinal cord. It is a medical emergency. If not treated, can lead to a cerebral edema, permanent disability, and even death. In the classification, it can be divided into acute, subacute, and chronic. Acute we see in a bacterial meningitis, and subacute picture is mostly seen in tubercular and viral meningitis, whereas in a chronic is seen in fungal meningitis. According to the place, it can be divided into community-acquired meningitis and nosocomial meningitis. The organisms which are seen in community-acquired meningitis are strep pneumoniae, Haemophilus influenza, Neisseria meningitis. And in more than 50 elderly and immunocompromised patients, we should be aware of Listeria monocytogenes. In the nosocomial meningitis, we see the organisms such as Coagulase negative Staph aureus, Propionibacterium, and aerobic gram-negative bacilli. The risk factors could be extremes of age, alcoholics, diabetes, leukemias, lymphomas, HIV, immunosuppressants, and some prosthetic devices like BP shunt, IV drug abuses, splenectomy patients. These are the symptoms and signs, and we usually see fever, headache, neck stiffness with altered mental status, and signs we observe neck rigidity, Kernig sign, and Leuchkis signs. The portal of entry for a meningitis would be hematogenous spread, extension from gastrointestinal structures such as otitis media, sinusitis, and patient with a prior history of recent neurosurgery, head injury, And in some cases, there would be extrapulmonary manifestations of pneumonia as seen in pneumonia.
Dr. You have to unmute yourself. You're on mute. Kindly unmute yourself.
Hi, any issues?
Is it audible, ma'am?
Yes,
I
sir,
can
you're
hear you,
audible
Hari.
now.
Hari.
Okay. So sorry for this. So I'll be covering this topic under the following headings. So coming to the definition, inflammation of pia and arachnoid meninges that cover the brain and spinal cord. It's a medical emergency. If not treated, can lead to cerebral edema, permanent disability, and even death. In the classification, it can be divided into acute, subacute, and chronic. Acute, usually we see in a bacterial meningitis. Subacute, we see in a viral and tubercular, and chronic is seen in a fungal meningitis. According to place, it can be divided into community-acquired and nosocomial. Community-acquired, we see the pathogens such as strep pneumonia, Haemophilus influenza, and Neisseria. In elderly and immunocompromised patient, we should cover Listeria monocytogenes. In the nosocomial thing, most commonly seen is gram-negative bacilli, cons, and Propionibacterium. The risk factors for meningitis would be extremes of age, alcohol, diabetes, patients who are using immunosuppressant drugs, and with the prosthetic devices such as VP shunt. These are the symptoms and signs. The most common symptoms which we observe are fever, headache, neck stiffness, and altered mental status. The signs which we observe is neck rigidity, Kernig signs, and Buchigan signs. The portal of entry. The portal of entry for the meningitis would be a hematogenous spread, extension from juxtacranial structures such as otitis media, sinusitis, recent neurosurgery, head injury, and in mycoplasma, extrapulmonary manifestations of pneumonia. In the investigations, we cover the routine blood investigations. Blood culture positivity is around 30 to 80% of all the patients with bacterial meningitis. Chest radiography, it is very useful in identify the mycoplasma, legionella, or tuberculosis. Lumbar puncture, it should be performed in all the patients who are suspected to meningitis. It is the IDSA criteria. These are the IDSA criteria for undergoing CT scan prior to the lumbar puncture. These are elderly patients, immunocompromised, history of CNS disease, and presence of a raised ICP features such as seizures, papilledema, decreased level of consciousness, and focal neurological deficit. In the CSF analysis, we look for opening pressure, TLC, DLC, protein, glucose, and gram stain and culture sensitivity. The main differentiating feature between bacterial, viral, fungal, and tubercular would be the neutrophilic predominance in the bacterial, whereas the rest show lymphocytic predominance. So the other test which can be done is PCR assays, CSF lactate, CRP concentration, and procalcitonin. The CSF lactate is a point of care test. The CSF lactate concentration of more than 4.2 has a good sensitivity and specificity for bacterial meningitis, especially in the post-operative neurosurgical patients. CRP has a high negative predictive value in the diagnosis of bacterial meningitis. If CRP is negative, we can rule out a bacterial meningitis. In the neuroimaging, contrast enhanced MRI brain would be preferable. Mostly we see a leptomeningeal enhancement in it. The characteristic features of neuroimaging would be frontotemporal changes in herpes simplex encephalitis, in tubercular meningitis, basal exudates, and multiple ring-enhancing lesions. In Japanese encephalitis, thalamic and midbrain changes are seen, and predominantly basal ganglion ring-enhancing lesions are seen in toxoplasmosis and in immunocompromised patients. Coming to the management, routinely airway breathing circulation, blood glucose, vitals, GCS, and appropriate fluid resuscitation. The mainstay of the management would be administration of parenteral antibiotics. It should be administered as early as possible. We should cover broad spectrum antibiotics covering both gram-positive and gram-negative organisms, which are having a reasonable CSF penetration and bactericidal. The reason is the CSF sterilization usually takes 4 to 6 hours after the initiation of antibiotics, even with the most sensitive organism. The initial choice would be the ceftriaxone 2 gram IV BD along with the vancomycin 1 gram IV BD to cover the penicillin-resistant streptococci. So, in suspected ventriculoperitoneal shunt infections, one agent should be taken which should cover anti-pseudomonal, which should be having anti-pseudomonal activity such as cefepime, ceftazidime, or meropenem, along with the vancomycin. In elderly and immunocompromised elderly patients and immunocompromised patients, the listeria coverage should be taken with ampicillin 2 gram IV 4th hourly. If the organism is subsequently found to be resistant to the carbapenem, colistin or polymyxin should be substituted for meropenem and also need to be administered by the intraventricular and intrathecal route. The role of intraventricular antimicrobial therapy is it is useful in a highly resistant organisms which are sensitive to the antibiotics with a poor CSF penetration, where the systemic therapy wouldn't be enough. The commonly used antibiotics given through intraventricular route are vancomycin, gentamicin, amikacin, colistin, and polymyxin B. Among these, we frequently use colistin. The dose is 10 mg and polymyxin B 50 lakh units. These are the duration of antibacterial management. For the Neisseria meningitis, duration is around 7 days. For Hib, 7 days. Streptococcus pneumonia, 10 to 14 days. And Listeria monocytogenes, we should be giving the antibiotics for more than 21 days. Coming to role of steroids in meningitis, corticosteroids significantly reduce the hearing loss and neurological sequelae, but it did not reduce the mortality. The current guidelines recommend the use of IV dexamethasone 10 mg or 0.15 mg per kg in children every 6th hourly for 2 to 4 days. It should be started just before or at the same time of the antibiotic administration. These are the variables which are associated with adverse clinical outcome: elderly age, low GCS at the time of presentation, involvement of cranial nerve, presence of cranial nerve palsy, that is 6th cranial nerve palsy in tubercular meningitis, CSF leukocytes and gram-positive coverage on the CSF gram-stem. What are the complications? These are the complications which are seen in bacterial meningitis, that is hearing loss, cerebral edema, DIC, brain abscess, and stroke. For the prevention and prophylaxis, the vaccination for meningococcus and pneumococcus and Hib. For meningococcal contacts, the prophylaxis which we take is rifampicin 600 mg BD for 2 days, ceftriaxone 250 mg IM once, or oral ciprofloxacin 500 to 750 mg once. Thank you.
Yeah, go with the next presentation, Srihari.
So next topic would be breaking bad news and empathy. So I'll be covering this topic under the following headings.
Can you hear?
Yeah, we can hear you.
Dharamendra, you have to finish by 8, eh? I hope you are aware of the timings.
Well noted, sir. Well noted, sir. We are ready, waiting for the. How are you, sir? Good evening, sir. We are
And
ready.
I got stuck. I couldn't join at 6 for an emergency, but around 6:30 onwards, I'm here. I'm listening to that entire proceedings. Please go ahead.
Dr. Srihari, you have to stop this presentation and start the new one.
Yeah, can you
Okay,
hear
if there-
Srihari?
If there is any issue, let us know. I'll start.
Is it visible now?
Dr. Sai, madam, is everything okay there? You're starting or there's an issue?
We're starting. Just a minute. Just a minute.
Okay, please.
Okay.
Okay, ma'am.
Okay, the next topic would be breaking bad news and empathy. So I'll be covering this topic under the following headings. So definition of the bad news, any news that seriously affects the patient, its view in the future. Situations where there is a feeling of no hope or any information that is not welcome. Examples would be a poor prognosis related to chronic diseases, cancer diagnosis, genetic disorders, lifelong illnesses like diabetes, hypertension, HIV, treatment failure, disease recurrence, or iatrogenic adverse effects. Objectives of the Breaking Bad News would be in terms of ethical, professional, human rights, and legal, which gives the patients or family time to plan, adapt, and help in a decision making. It improves the doctor-patient relationship and trust. It reduces the physician stress and burnout. The challenges of a breaking bad news to a person. The physician challenges are lack of a formal training, cultural differences and language barriers, uncertainty about the prognosis or the treatment outcome, and fear of causing harm. The patient challenges would be intense emotional reactions such as fear, denial, stigma, low health literacy, and having a past negative experiences. These are the various practical methods for a breaking bad news, which would be a spikes approach, ABCDAC approach, breaks approach. So I'll be dealing about the spikes approach. Spikes, this is setting and listening. S is for setting and listening. Arrange for a privacy in a quiet room. Introduce yourself. Review clinical facts about the meeting. Involve key relatives if appropriate. Sit down and minimize the interruptions. P is for patient perception. Explore patient understanding. That what do you already know about the condition and identify any misconceptions and fears. Invitation, I is for invitation. The third step would be ask how much detail the patients want. Because some of the patients would prefer a limited detail where other wants everything. Respect the choice to receive or decline the full information. Knowledge would be giving a warning shot that I am afraid that I have a bad news. The information should be shared in a clear language and it should be shared in a small chunks rather than telling the whole story. So avoid jargon and vague phrases. So this is the importance of empathy and cultural context in the breaking bad news. Empathy, the definition of empathy would be the ability to imagine oneself in another place and understanding their feelings, desires, ideas, and action. Allow time for emotional responses. Listen actively is a key. Acknowledge their feelings. Express empathy. I can see this is a very difficult for you like that. So offer tissues. Support body language. Silence when needed. So how to deal with the cultural context? It believes about the disclosure. Some patients need a full transparency versus some patients would be needing about hiding of the information to them as well as the family members. Decision making style, it would be an individualistic approach or collective health decisions of rituals and practices. So if they request for any prayers or last rites or spiritual leaders, we should allow them. Language and interpretation should be avoided to avoid any miscommunication. But finally, we should summarize and subsequent plans. Summarize what about the discussed, make a clear plan for the next step, offer a psychological support and resources, multidisciplinary involvement. We should schedule a follow-up. So how to handle the conflicts and unrealistic explanation in the breaking bad news. The conflicts arise mainly due to denial and hope, miscommunication, emotional overwhelming, cultural and religious factors. So how to handle the conflicts? We should listen actively, stay calm, empathetic, even if confronted with the anger. Team alignment. Ensure that the team shares a unified message. Acknowledge emotions. Recognize distress before giving them more information. How to handle unrealistic expectations. So we should explore the expectation. Ask the family what they are hoping for. So balance hope with the reality. Example, like we will continue the treatment to keep her comfortable, but the treatment would not reverse the disease. Emphasize on the quality of life and comfort care. If still conflicts persist, then involve the senior clinician or palliative care specialist. This is the documentation of breaking bad news in the ICU. So we should mention the date and location, date and time and the location. So how many members are there involved in the location. Next, we should document all the summaries. These would be steps. So common pitfalls in breaking bad news would be inadequate time, inadequate information, giving news at a doctor's speed, not allowing time for the responses, false reassurances about the future, allowing delay to remain, removing all the hope and inadequate documentation. Thank you.
Yeah, we've corrected, well said, covered everything. Anindam sir, anything to add? We shall go with the next presentation.
Yes, ma'am. Please move on to the next presentation.
అక్కడ స్టార్ట్ అవుతుంది. So, can you hear me?
Yes, ma'am.
Yeah, can you hear me?
Yes, ma'am. Yes, we can hear you.
Yeah, shall I go ahead with the presentation?
Please.
Okay, so I'll be talking about, I'm a senior critical care consultant at Apollo Hospitals, Visakhapatnam. I'll be, just a second. Yeah. So I'll be talking about end of life care in ICU, the legal status of AMT in India, and the process of withdrawal and withholding life support. And these are very often asked, and any case scenario and practical will end up with end of life care issues. Is the voice okay? Sudeshna, is the voice okay?
Ma'am, it's a little. Where are you speaking from? Can you just
For end of life care and palliative care and intensive care unit has covered everything, and one should go through it to answer the questions well. And now the first question I'll be should they lose their capacity, and it should be always in the best interest of the patient, and are collectively termed foregoing of life support treatment. And any of these things like withholding, withdrawing, or DNR, you have to follow the ethical principles which are very basic, like autonomy, beneficence, non-malfeasance, and distributive justice. In India, it is called the Living Will, and it is approved by the Supreme Court in 2018 as a fundamental right. And the guidelines were recently simplified in 2023, wherein it is very easy to implement the process of any advanced medical directive, withholding, or withdrawing. So the first thing, as I told you, it is the patient's autonomy, wherein you are upholding the right to dignity. They have the future healthcare planning, and they have very clear specific instructions regarding their future health, or their treatments. Then what are the key requirements for a valid AMD in India? One should be they should have the mental capacity. The witnesses, there should be 2 witnesses. It should be attested by a gazetted officer, or a notary has to be done. And this has to undergo the 2-tier medical board, the primary and the secondary medical board. And no, the judicial involvement, like previously till 2023, there was a first-class judicial magistrate who has to approve this, and this has been removed in 2023 amendments. So how to create, one wants to create an AMD. So you have to understand your wishes. You should be very clear of your end of life care wishes. Create a document. And in this regard, the Vidhi Center for Legal Policy offers templates and informations. Sign with witnesses and get it notarized, and preserve the document, one with you and one with the treating doctor, and at the municipal office also. And this is a subtopic in the end of life care. It is shared decision making. A dynamic exercise in which the healthcare team for a patient without capacity understands shared decisions with an appointed proxy or family regarding the medical treatment of a patient. It is very simple. You don't have an AMD, so your doctor and the family members or the next of kin will decide on what are the treatment goals. It is as simple as that. So what are the principles of withdrawing of life support and compassionate care? As I said, the principles remain the same anywhere: autonomy, beneficence, non-malfeasance, and distributive justice. But you have to be open, honest, and compassionate, and communicate, and compliance with legal requirements, and transparency and documentation, and transitioning to palliative care. What did the Honorable Supreme Court say regarding this? LST is legal. Anybody can go for the withdrawal or withholding of the care. And you have to again apply the fundamental rights, that is autonomy, privacy, and dignity. AMD that meets the specified requirements is legally valid, and any of these should be approved by the primary medical board, secondary medical board, and active euthanasia is not lawful. So coming to the primary medical board, which we have seen in the process of EOLC, consists of 2 subject experts along with the primary physician. They can be from the same hospital, and they can be appointed by the medical superintendent of the hospital, or it can be formed in the hospital itself. Then what is secondary medical board? It constituted by the hospital or institution, consists of 1 registered medical practitioner nominated by the CMO or the DMHO of the district, and at least experience there. And Supreme Court, that is the notice of primary, and both the on this side, here. more question, withhold. And this is nothing but discontinue ongoing life support in a terminally ill disease. Or withholding is you're not starting any treatment. Like the case which I told you is wherein he's bedbound, there is recurrent hospital admissions, the quality of life is less, very aged, and the futility of care is very clearly seen in such cases. There is no point in starting him on treatment and withdrawing. You should discuss regarding the withholding of care in such withholding. So you have the inappropriate, you have come to a conclusion that it is inappropriate to continue life sustaining treatments. Then the primary medical board is also of the same opinion. Then you have one or more multidisciplinary meetings with family or surrogates, discuss the prognosis, the treatment options, and you come to a conclusion. Here comes the shared decision making, which is a question wherein you discuss with the medical team and the families, and you check whether there is an advanced medical directive. And if both of you are on the same page, then refer it to the secondary medical board, wherein the secondary medical board has to give the opinion within 48 hours. If during this process, either the family or the primary medical board or the secondary medical board are not in the same page or on the same page, there is a difference of opinion, then you continue the full support pending conflict resolution, and continue full support and resubmit to SMB or the secondary medical board or the clinical ethics committee where available to help resolve the differences. Till there is a resolution of the differences, you continue with the care, and once it is sorted out, you can go for the withdrawal of the support, life support, and you inform the district judicial officer. Then this is one more question. Communication in end of life care. Why you should communicate is to elicit complete information, to build trust and confidence, convey prognosis, breaking bad news, which was already discussed, elicit the patient's values and wishes from family and surrogates, to accomplish shared decision making, resolve conflicts with both family and the treating team, and to provide colleagues a supportive climate to foster professional integrity and satisfaction, preventing burnout. So the communication, what you should communicate, the essential elements of physician-patient family relationship include both verbal and non-verbal communication, information sharing, empathy, and participatory decision making. And it is central to humanizing medical care in a fraught environment. And there are 7 tips which are mentioned wherein you prepare, you have the meeting is instituted or is conducted, and you have an uninterrupted attention, connecting to a story, understanding patients in their socio-economic context, agreeing on important issues and negotiating common grounds, summary, and the way forward. These are the 7 tips you should mention in your answer for a good communication. And emotional and spiritual support according to the patient's family wishes, and communication training. It's not just talking whatever comes, it's according to your training. That is either you go with the spikes protocol or nurses to address emotions or value, to facilitate family meetings. And words are very important. The choice of words are very important, and it's been repeatedly emphasized. And conduct of multidisciplinary family meetings and new approaches, like you can use AI in these cases. So after doing all this, documentation itself is a 5 marks question, which you need to answer. All the multidisciplinary family meetings have to be documented and signed by the primary and the secondary board. And you have a very specific forms or institutional forms, like the AIMS has a form, the Blue Maple, which is very famous from the Manipal hospitals, which itself has all the documented format in it. So I'll move on to the second topic. Shall I? Dharani? Anything that you want to add?
End of life care and
Okay, shall I go on?
especially
Okay, now the
Continue,
second
madam.
topic is metabolic encephalopathy. Common causes of acute encephalopathy are usually hypoxic, ischemic, systemic diseases, and toxic agents. This can be one of the classifications, and the most common are shock, azotemia, hyperammonemia, or hypoglycemia, hypothyroidism, vitamin B deficiency, hypertension, antibiotic toxicity, chemotherapeutic agents, and this is the paper, this is the review article from which it is well described, and most of the topics have been covered in metabolic encephalopathy. So the confounders for this can be shock, wherein usually you see the ischemic changes with MAP thresholds of 50 mmHg, and every organ has its own MAP, like the cardiac coronary perfusion pressure is at 65 mmHg and renal at around 70 to 75. And the other confounding factor for encephalopathy is with the continuous ongoing sedation in our patients, especially with fentanyl, wherein prolonged infusions causes decreased clearance, and there may be some amount of encephalopathy induced by fentanyl. So what happens in encephalopathy, each organ, individual organs, when we see the failure like the liver failure or renal failure or lung hypoxic injury, there is, in case, suppose you take the example of liver failure, there is a production of ammonia, the urea cycle is not taking place, the ammonia gets converted into glutamine, and the astrocytes are filled up, and there is no method that the glutamine is eliminated, and the swell up leading to osmotic stress. And the same happens in renal failure, where there is a glutamate accumulation and the receptors are blocked, and this causes edema of these cells. In cardiac conditions, there is hypoperfusion, and cortical mantle is involved because of the hypoperfusion. And caudate nucleus and pallidum are more specific in case of hypoxic and hypotension injuries caused by, in case of multi-organ failure. So these are the imaging in metabolic encephalopathy is also one of the questions. Maybe they'll ask you in the practical also. So Wernicke encephalopathy, you see thalamic and mammillary bodies and tectum. Whereas if you take central pons is involved in pontine myelinosis, and press you have parieto-occipital injuries, and corticospinal tracts are involved in cobalamin deficiencies and vitamin deficiencies. So these are MRI. What is it specific? MRI can be helpful, but you can't conclude just by seeing the MRI. Usually it is non-specific, and toxic and metabolic brain disorders display general imaging patterns. Like I told you, Wernicke encephalopathy, bilateral thalami are involved, basal ganglia is involved, dentate nuclei in case of metronidazole toxicity, corticospinal tracts in vitamin B12 deficiency, corpus callosum in anti-epileptic drugs, and parieto-occipitals in press. These changes you need to pick up. So coming to antibiotic toxicity, like metronidazole, if you give for a prolonged period of more than 3 weeks, patients are prone to develop encephalopathy. And cefepime, because it crosses its blood-brain barrier. Colistin, acetylcholinesterase inhibitor release is stopped by colistin, and henceforth all these antibiotics result in some kind of encephalopathy in certain group of patients. And neurotoxicity of chemotherapies like alkylating agents, antimetabolites. We often see post-chemotherapy patients coming with encephalopathy. We do an LP, and they land up, and the LP is suggestive of high protein and lymphocytic pleocytosis. We often think it is tuberculosis, but neurotoxicity of chemotherapy can pose this picture of predominant lymphocytic pleocytosis, and increased protein in case of an LP. So initial approach to encephalopathy, how do you go about it? You document detailed neurological findings, new basic metabolic panels, ABG, and ammonia, serum ammonia and lactate, MRI if required, and 24-hour EEG monitoring, CSF for inflammatory and infectious markers, electrolytes and vitamins levels, and discontinue or replace antimicrobials, and consider genetic consultation and additional focus tests, example in case of acute intermittent porphyria. So each, like you can, they can ask you about each, or in metabolic encephalopathy, you can cover about hyponatremia, wherein the levels of less than 115 millimoles may cause cerebral edema, or rapid correction also proposes for cerebral edema, and people like patients with long-standing alcohol and malnutrition are more prone for this. Hypocalcemia, on the other way, presents with the neuropsychiatric symptoms such as subtle personality changes and concentration difficulties, confusion, depression, dementia, and bedside you see the Chopsticks and Trousers sign, and levels less than 7.5 causes several neuromuscular manifestations. Septic encephalopathy, if nothing is there, we come to a conclusion of septic encephalopathy, usually results from microcirculatory abnormalities, altered blood-brain barrier permeability, and inflammatory cytokinins. There is a reduction in monoamine neurotransmitters, and EEG usually suggests diffuse slowing, and as it worsens, there may be triphasic waves or burst suppressions. LP is usually normal with mild elevation in proteins. And these are metabolic toxic intermediates and cofactor deficiencies like porphyrias, Wernicke's, and pellagra and melas, that is mitochondrial encephalopathy, lactic acidosis, and shock. Then hepatic encephalopathy, as I told you, you have elevated ammonia levels. It can be acute or chronic, and there will be some precipitating agents like GI bleeds, diuretics, or drugs or opioids or alcohol consumption along with infection. And arterial ammonia concentrations are frequently elevated, and CSF glutamine levels are very sensitive tests, and EEG usually shows triphasic waves. And treatment is nothing but correction of coagulation parameters, electrolyte abnormalities, volume depletion, hypoxemia, and identification and treatment of precipitants. Again, uremic encephalopathy, you see azotemia more than in patients. Some patients, more than 100, you see the encephalopathic features. On dialysis for 2 or 3 sessions, the encephalopathy improves. Again, EEG shows slow waveforms and high voltage delta waves. And there is accumulation of guanidine and glutamate in uremic encephalopathy. Hypo and hyperglycemia are very, the patients will have focal neurological deficits. These are the only 2 conditions where they are different. And I mean, sometimes the patient may have focal neurological deficits, and they usually mimic stroke, which you have to be cautious and you have to correct the underlying cause for hyperglycemia or DKA. So Wernicke encephalopathy is important, and as I told you, bilateral thalamic involvements are seen with associated usually with thiamine deficiency, and people with fasting and receiving parenteral nutrition, heavy alcohol consumptions, recovering from gastrointestinal surgery. This should be at the back of mind, and triad of confusion, ataxia, and ophthalmoplegia are the hallmark features. And horizontal nystagmus is usually seen, and bilateral abducens palsy, 6th nerve palsy is very common. You give intravenous thiamine to the dose of 500 mg IVTID, and ocular abnormalities are the first manifestations to respond therapy, and other features will slowly recover. So the treatment is nothing but you treat the underlying cause and supportive therapy. Thank you. Dharani, you can go with the last. Hello. Sudeshna.
Yes, ma'am. I'm just trying
Dr.
to-
Dharani is left with one topic, which will be of 5 minutes. If it is okay, he'll continue with that.
Actually, Dr. Dharani is logged out. That's a main issue. Let me connect with him.
So Arvindam sir has anything to add on? Sir? Dharani, you want to present last one? Yeah, yeah. So Dharani is connecting. He'll be finishing in 5 more minutes. We are
Yes,
done.
Sudeshna. Just a minute.
So we are
fifth
done
one
with
is
11
calling.
topics and we are left with only one topic, which will be of 5 minutes by Dharani.
Yes, please.
So he has some network
Complete
issues.
that.
He's connecting. So
Please,
any
please.
inputs from you, sir?
Now you please do. Let's complete on that. And then most of you have done a wonderful job of compiling and giving away the information. You have to share the presentation.
Dr. Arindam, sir.
Dharani, please go ahead.
Krishna, madam, or,
Audible.
yeah.
Yeah. Go ahead. Screen share.
Okay, I hope you see the screen and I'm audible.
There's some network issue. We can't hear you properly. Neither your screen are shared. So
You can hear me now?
We can
You
hear
can hear me
you.
now?
Your slide is also seen.
Yeah, I think you can, yeah, fine. So coming to the last topic of the day, acute ischemic stroke management in ICU, very common, and an exam also has huge weightage. So the entire concept of management of acute ischemic stroke, especially currently in India is to reduce the morbidity and mortality, especially the morbidity. So every second that the artery is cut off, we lose 1.8 million neurons. So more neurons lost, more disability, more livelihood loss. So that is the main thing that we need to, insist. So the learning objectives of this session is understand the pathophysiology, reperfusion therapies, master the ICU management, pre and post reperfusion, recognize and treat complications, both hemorrhagic, transformation, edema, seizures, and infection. Okay, we are discussing from the latest 2024-2025 guidelines, and the references are below each slide and at the end of the presentation. So, acute ischemic stroke comprises 85% of the strokes. Significant ICU morbidity and mortality. There is regional variations, in the outcomes based on the availability of mechanical thrombectomy and based on the availability of prompt diagnosis and management. So the pathophysiology is the ischemic core. Ischemic core is nothing but irreversibly injured tissue. Penumbra is the salvageable tissue. So the target of the neurologist or the neurocritical care physician with the interventional radiologist is salvageable tissue. Target the salvageable tissue. There is a time-dependent progression of the clinical signs, especially the imaging. It is very important for the intensivist to understand the intricacies of clinical imaging, which I'm going to stress. So the tissue damage is awareness in the medical community as well as non-medical community. So there are terms we need to understand like hub spoke models, mothership versus drip and ship, which we are going to discuss. The goal is to minimize the time to reperfusion. So in the initial emergency medicine department, what we are going to do, rapid airway breathing circulation management, and checking the basic NIHS score, checking the blood glucose. Hypoglycemia is a stroke mimic. So they'll ask you why to check the blood glucose. Hypoglycemia is a stroke mimic. So acute stroke code activation and immediate IV thrombolysis. So non-contrast CT is the imaging of choice. So the to do the non-contrast CT and you time of 10 go to CT. Okay, so non-contrast CT. Just rule out the hemorrhage and you'll get the aspect scoring as well. Aspect scoring is Alberta stroke prevention and CT score severity scoring. So based on the aspect scoring, you offer them thrombolysis and thrombectomy. Basically, it is a scoring system which grades the amount of tissue involved with ischemic stroke. Okay. So this is the aspects original study form taken it from up to date. You can see that the aspect score basically checks the neurological ischemic injury at two levels. Okay, one is at the standard axial cuts, one is at the level of thalamus, and the other one is at the level of basal ganglia, rostral to the basal ganglia. Okay, so basically it studies the early acute ischemic stroke CT changes. So by this, what we are trying to gauge, the salvageable tissue, the amount of tissue that is affected, and you can provide them any reperfusion therapy, either thrombolysis or thrombectomy, or both, one followed by the other. Okay. So aspect scoring is on a grade of usually you grade it with 10. 10 is equal to normal. Okay. So aspects assist in thrombectomy causing decisions, and especially it is designed for anterior circulation strokes, and it is limited use in posterior circulation strokes. So this is the early ischemic changes in non-contrast CT head. What you can see is basically, this is a CT scan of a 59-year-old man, 3.5 hours into the ictus after the acute ischemic stroke. You can see there is a hypodensity. There is a hypodensity. You can see there is a hypodensity. The hypodensity is followed by loss of get hypotension.
Mhm.
I think we lost Dr. Dhanendra. I would request, I think,
Yeah, we can go ahead with the next presentation. Almost everything we have covered. Probably this
okay.
needs 2 or 3 minutes, but we shall not waste time as it is already 8:15 or 8:20. So please go on with the next topic.
Okay.
Yes,
So I
I
think
think that would be nice. So the last segment of our entire domain, we have the oncology, hemato-oncology, hematology, and certain other related process. So I invite Sudipto and Saurav, right? Where is Saurav is here? Dr. Saurav Taneja.
Hello, good evening.
Yes, and Sudipto is here. I can see. Yes, Saurabh is also here. So all of you know Saurabh is my colleague from Sir Gangaram Hospital and one of the brightest mind in critical care today. And Sudipto works for Tata Medical Center in Kolkata. Though he was at one point he was in Delhi, he trained himself in Delhi, but now he is spreading his wings in Kolkata as of now. That part, and he has single-handedly he had sort of popularized oncology critical care in the eastern part of the country as well as throughout the country itself. So I hand it over to Dr. Saurav Taneja and Dr. Sujito Mukherjee to run the proceedings as the guiding faculty, and there are multitudes of as uh, youngsters who would be presenting the topic, and I'm sure that you have around 12 topics along with certain number of subtopics itself, and we would try to finish it off in 2 hours time. So over to you, both of you.
Thank you, Dr. Rhythm. You've not changed since the last 17 years, so it's the same to see you, and it's a pleasure. And thank you for the kind introduction. Dr. Rhythm is a elder brother and mentor to me since maybe 2 decades now, and Sudipto a dear friend since the last 1.5 decades. So it's great to have them both here. And we'll be joining with three brilliant minds who actually passed their DRNBs in the last year, and they are Dr. Dilip, Dr. Maniraj, and Dr. Gurkirat. And I can vouch for all three of them. They are very intelligent, hardworking, diligent, and they passed the DRNBs in the first attempt, and they have worked hard to present this. So without wasting any time, I will be starting with the first presentation, Dr. Dilip. He'll be touching upon few questions. So there are three of them. They'll be touching on 4 or 5 questions each, and we'll be trying to finish in the next 2 hours. Yeah, Dr. Dilip, over to you.
Audible.
Yes.
And other.
Start.
Okay. Few questions and a question surgery. Question marks and refit room for 5 marks. We'll start. Normal bubble length would be 800 of fluid. It passes through the small bubble every single form of 7 liters are absorbed in the small bubble and 2 liters in the large bubble. Most nutrients they are absorbed in the jejunum. B12 and bile salts are absorbed in the distal ileum, and certain nutrients like magnesium are absorbed proximal. So when do bubble syndrome? It is defined as less than 180 to 200 centimeters of remaining leading or nutritional and fluid supplementation. So you can enumerate a bit about the etiology, the cause of bubble syndrome, and most of the cases, surgical complications, short bubble, and few cases are due to mesenteric infarction, arterial or venous thrombosis leading to bubble resection, radius, Crohn's disease, and benign conditions and volvulus can also lead to short bubble. So coming to the types of short bubble, this is important because the clinical features and the risk for prognosis depends on the type of bubble that is resected. So as we know, we'll see about the 3 parts, the jejunum, ileum, and colon. And depending on what part is resected, we can divide it into 3 types. The type 1 would be a terminal jejunostomy, where most of the colon and ileum are resected and the jejunum is preserved. And this is important because this type 1 has a risk of post-surgical dehydration and a lot of electrolyte imbalances. And the risk for permanent dependence on parenteral nutrition is very high. Type 2 would be a jejunocolic anastomosis where the ileum is resected. It leads to a lot of complex diarrhea, steatorrhea, small intestinal bacterial overgrowth, malabsorption, vitamin B12 deficiency, oxalate-induced nephrolithiasis, and so on. And most of these cases require supplemental parenteral nutrition to a degree. And the last degree would be a jejuno-ileo-transversostomy, where the jejunum is resected and at least 10 centimeters of the ileum and colon are retained. And in this type, malnutrition is very rare and there is usually no need for any parenteral support. So coming to the phases of short bowel syndrome, there is an acute phase which takes place immediately post-surgery and lasts up to 3 to 4 weeks. And a lot of metabolic derangements and fluid and electrolyte losses occur in this acute phase. This is followed by a adaptive phase which takes a period of months to years, in which the remaining bubble, it has an adaptation process. Could be both structural adaptation to increase the absorptive surface, or could be a functional adaptation where the transit time decreases to maximize the time available for absorption. And the third phase would be a maintenance phase. So you'll enumerate a bit of a few lines about complications of short bowel syndrome. You can divide it into complications which are related to the short bowel syndrome as such, like diarrhea, which is the most debilitating complication, dehydration, hyponatremia, acute renal failure, something called as the IFALD, intestinal failure associated liver disease, and a lot of metabolic complications like cholelithiasis, oxalate nephropathy, hypomagnesemia, and D-lactic acidosis leading to encephalopathy. You can also mention about the complications related to the access, which is required for long-term parenteral nutrition. And you can mention about all the mechanical complications, the bloodstream infections due to the catheter or venous thrombosis. And the last, you can mention about long-term metabolic complications like metabolic bone disease due to vitamin D deficiency, osteoporosis, osteomalacia, iron deficiency anemia, or manganese toxicity. So management of short bowel syndrome, you will divide it into 2 phases, the acute phase and the maintenance phase. Acute phase, in the initial part, you will be mainly replenishing the fluids and electrolytes with the aim of transitioning over to a parenteral nutrition and gradually to enteral nutrition. So in this phase, you will be having a combined strategy such as enteral to parenteral or oral enteral parenteral. Of course, you should keep a watch on close monitoring of the patient's total output, both fecal and urinary, and you have to replace the IV fluids and electrolytes accordingly. And once the patient stabilizes after surgery, aim would be to start parenteral nutrition as early as possible. Feeding via the enteral route is desirable because it preserves the blood flow and prevents mucosal atrophy. But again, in a short bowel, you don't know how much the intestine is able to absorb, and malabsorption would be an issue. And coming to the maintenance phase, here you aim to transition over from the parenteral nutrition to a complete enteral nutrition and eventually cured nutrition by mouth over a period of months to years. And there is no specific diet which is recommended for short bowel syndrome, although there is a recommendation to avoid sugars. 5 or small meals a day, small frequent meals are recommended rather than 2 or 3 large meals as we usually do, with additional vitamins or mineral supplementation. And coming to the prognosis, those with a bowel length more than 180 centimeters, they generally do not require any parenteral nutrition. About 50% of short bowel syndrome cases, they evolve into chronic intestinal failure, depending on the bowel length. Those with a bowel length of more than 90 centimeters, they require IV support, IV nutrition for years, and it is usually reversible. Whereas those with a bowel length of less than 60 centimeters tend to require lifelong parenteral nutrition and they tend to be irreversible. So these are some of the medications you can use to in the late phase of short bowel syndrome. You can have a look at it later. Antidiarrheal medications, enzyme replacement, bile resins. The thing that is coming up recently in a big way these days is teduglutide, which is a glucagon-like peptide 2 analog, and it increases the intestinal absorption. It is approved by the US FDA in 2012, and in a recent phase 3 trial, it has shown a more than 20% reduction in the weekly parenteral nutrition volume from the baseline, and it has maintained it to week 24. And teduglutide in short bowel syndrome has been, it has associated with improvement in the quality of life scores. And at the last, you'll mention a bit about the surgical indications. In those with less than 60 centimeters of the small bowel or those with a complication from long-term TPN, you consider surgery. It could be a Bianchi's procedure where the intestine is lengthened and then tapered to maximize the absorptive surfaces, or it could be an intestinal transplantation. And the next question would be refeeding syndrome for 5 marks. We will be discussing the pathophysiology, clinical features, risk groups, and management. So what is refeeding syndrome? It is a series of metabolic disturbances related to the transition from a prolonged catabolic state to an anabolic state due to the abrupt reintroduction of nutrients. It is very important in the critical ill patients because there are already 1 or more organ failures. There is a long period of hospitalization, long period of starvation and inadequate calorie intake and comorbidities. So how does it occur? What is the pathophysiology? In a chronic starvation, the body adapts to the nutrient depleted state in order to preserve energy. The hepatic glycogen stores deplete. There is a metabolic shift from the carbohydrates towards fatty acid oxidation, leading to a decline in the insulin activity and an increase in the counter-regulatory hormone activity. And this leads to a progressive depletion of the intracellular substrates, including all the vitamins, minerals, electrolytes, to maintain the serum levels. So they move from the intracellular part to the serum to maintain normal serum levels. But when you abruptly start refeeding, it leads to an abrupt increase in the insulin secretion. And there is a change in the metabolism from lipid peroxidation back towards glycolysis. So this glycolysis again leads to reactivation of all the intracellular enzymes that were actually inactive before. And these enzymes require vitamins and cofactors. And this leads to an increased intracellular uptake of all these vitamins and cofactors. And the serum level drops. They move from the serum to inside the cell and the serum level drops. So this again a small graphical depiction where the switch to anabolism leads to refeeding syndrome. Classically, hypophosphatemia, hypomagnesemia, hypokalemia, and thiamine deficiency along with salt and water retention. These are the clinical features we see in a refeeding syndrome. So how does it manifest clinically? So you can divide it into according to the different electrolytes. Hypophosphatemia mainly leads to muscle weakness, tetany, rhabdomyolysis, respiratory failure, heart failure, and arrhythmias. Hypokalemia mainly leads to muscle weakness, arrhythmias, and Torsades de Pointes, along with hypomagnesemia. And hypomagnesemia also causes tetany, ataxia, and seizures. Thiamine deficiency is something that is more important. The initial part is a reversible part called as the Wernicke's encephalopathy. triad of ataxia, ophthalmoplegia, and confusion. And this is not repeated, it may progress to irreversible Korsakoff psychosis, which also has amnesia and confabulation. And because of sodium and water retention, it can lead to fluid overload and heart failure, pulmonary edema, and peripheral edema. So what are the risk groups in which refeeding syndrome occurs? I'll just mention a few of the important risk groups. Those with an unintentional weight loss over a short period of time, those with a low nutrient intake, that is starvation for more than 7 days, or a prolonged hypocaloric feeding or fasting, chronic alcoholics, elderly, depression in the elderly, patients with cancer, and those with increased nutrient losses like significant vomiting, diarrhea, inflammation and dysfunction of the GIT, and chronic pancreatitis. So how do you prevent refeeding syndrome? Again, you need to assess the potassium, phosphate, and magnesium. You need to assess the risk of developing refeeding syndrome. And if the levels are low, you replete the electrolyte levels prior to commencement of refeeding. You give him thiamine and other vitamin supplements for 10 days. And depending on the risk category, according to NICE, you start with the feeding. If it's a high risk, you start with a lower target, 10 kilocalories per kg per day, and you increase it slowly over 4 to 7 days. And if it's an extremely high risk for refeeding, you start with a lower target, 5 kilocalories per kg per day, along with continuous cardiac monitoring. So these are some of the recommendations according to Aspen to manage refeeding syndrome. Regarding the calories, you start with a lower caloric dose, 10 to 20 kilocalories per kg for the first 24 hours, and you advance by 33% of the goal every 1 to 2 days. And in those with a high risk of refeeding syndrome, you hold the initiation until the electrolytes are supplemented and normalized. Coming to electrolytes, you check the serum potassium, magnesium, and phosphorus before starting nutrition. You monitor every 12 hours for the first 3 days in the high risk patients, and you may monitor it more frequently depending on the clinical picture. And you replace electrolytes based on the standards of care. There is no recommendation when it comes to fluids, sodium, or protein. Coming to thiamine and vitamins, you need to supplement thiamine 100 milligrams before feeding or before starting any dextrose containing IV fluid in those patients at risk. You supplement thiamine 100 milligrams per day for 5 to 7 days or even longer in patients with severe starvation, chronic alcoholics, or other high-risk features, as we had seen earlier. And of course, at the last, you see the vital signs every 4 hours for the first 24 hours after you start feeding. In those with a high risk, you go with cardiorespiratory monitoring. And of course, your daily weight and intake and output charting. This is just a graph. You can look about it later. Summary of what we had discussed till now. Shall I move on to the next question, sir?
Yeah, please continue. Please continue.
Okay. So next we'll be discussing a few complications of transfusion, Trally, TACO, and graft versus host disease, and a sub question about hyperviscosity syndrome in the ICU. So coming to Trally and TACO, you begin with a small introduction. They are life-threatening transfusion reactions and a leading cause of morbidity and mortality associated with blood component transfusion. And both Trally and TACO, they present with the onset of acute respiratory distress, hypoxemia, within 6 hours of a blood transfusion, along with infiltration on a chest radiograph, indicative of the presence of pulmonary edema. So how does a Trally and TACO occur? The two-hit model is what is more commonly accepted nowadays. The mechanisms are different. For Trally, it is mainly an immunological reaction where the donor-recipient immunological conflict during which the antibodies to HLA are produced, or the presence of an anti-leukocyte antibodies in the transfusate, it mediates the interaction of the polymorphonuclear cells along with the endothelial cells of the pulmonary circulation, leading to neutrophil activation and adherence to the walls of the pulmonary capillaries. Eventually leads to release of intracellular proteases and edema. And another mechanism is by the platelets, which tend to form something called as NETs, neutrophil extracellular traps, and these cause direct pulmonary endothelial cytotoxicity. Whereas the TACO, it is a non-immunological phenomenon, mainly due to increased hydrostatic pressure in the pulmonary circulation, eventually leads to fluid leakage into the alveolar space, and it mimics the clinic of a left heart failure. So a bit about the pathophysiology. What is important over here is TACO is mainly a hydrostatic edema that mimics cardiogenic pulmonary edema, whereas TRALI is a permeability related edema, which is mainly non-cardiogenic. And the first hits and the second hits are also different for both TACO and TRALI. For TACO, the first hit is already a poor adaptivity for volume overload, those with cardiac failure, renal failure, or those with already a positive fluid balance. And the second hit would be a suboptimal fluid management on top of the first hit, leading to overload. Whereas in TRALI, the first hit would be an increased islet. Risk factors would be chronic alcohol abuse, old age, AKI, liver surgery, mechanical ventilation, increased CRP. And the second hit on top of this would be your antibodies, anti-HLA and anti-HNA. So there are definitions given for both TRALI and TACO, similar to ARDS definitions. TRALI is again, it has two types, the TRALI syndrome type 1 and TRALI type 2. TRALI 1 is the acute onset of hypoxemia with evidence of bilateral pulmonary edema and no evidence of pulmonary artery hypertension within 6 hours of transfusion and no other source of risk for ARDS. And TRALI type 2 would be those who already have a risk factor for ARDS or who already have a mild ARDS and who develop acute worsening of lung function. So the criteria would be the same. And additional criteria would be the presence of a stable pulmonary status for 12 hours before transfusion. For TACO, the definition is given by the NHSN 2016, where there is occurrence of more than 3 of the following criteria within 6 hours of transfusion, which is ARDS, positive fluid balance, elevated levels of BNP, radiographic signs of pulmonary edema, signs of left heart failure, and increased central venous pressure. So you can clinically compare TRALI and TACO. Few features are similar to both TRALI and TACO, like chest X-ray findings, dyspnea, and auscultation. But the things which are different are more important to mention in the examination hall. Coming to temperature, fever is a feature of TRALI, whereas it is not seen much in TACO. TRALI has hypotension and TACO has hypertension. The pulmonary occlusion pressure, PaOP, is less than 18 in TRALI, whereas it is more than 18 in TACO. And response to diuretics is very minimal in TRALI, whereas it is the treatment of choice in TACO, and there is a significant response. The type of pulmonary edema is mainly exudative in TRALI and transudative in TACO. WBCs in TRALI, there is a transient leukopenia because the neutrophils are sequestered in the pulmonary circulation, whereas WBCs do not change much in TACO. And the fluid balance can either be normal, positive, or negative in TRALI, whereas the fluid balance is almost always positive in TACO. So how do you manage TRALI and TACO? You stop the transfusion immediately. There is no definitive treatment. Treatment is mainly supportive. You give oxygen, support, mechanical ventilation, either by NIV or invasive. TACO, you go ahead with diuresis. ECMO may be an option. There are some strategies which can mitigate the occurrence of TRALI and TACO by screening of the donor based on the antibodies, anti-HLA, anti-HNA screening, deferral of the donor based on previous pregnancy or previous transfusions, or you can defer all female donors and use only male-only plasma donors because of the high incidence of HLA and HNA antibodies in females due to exposure to fetal antigens. There are some experimental therapies in the pipeline, but these do not have a definitive evidence right now, like anti-IL-10, IVIG, or IL-8 receptor blockade. So coming to the next topic would be a transfusion-associated graft versus host disease. It's a delayed and more often fatal complication of transfusion. 0.2 to 5% would be the incidence. It occurs because of the donor viable T cells in the blood or blood products in the transfusate. They attack the APCs in the host with various haplotypes and cause damage to the recipient tissues, mainly in the skin, liver, and GIT. It usually occurs 5 to 10 days after the process of transfusion. A few risk factors include elderly patients, immunodeficiency, those with history of multiple transfusions and prolonged transfusions, transfusion of fresh blood products, and those with a stem cell or bone marrow transplants. Clinically, you have to mention again skin, liver, and GIT. Fever, skin rash, diarrhea, jaundice, seizures, elevation of liver enzymes, elevation of bilirubin, eventually leading to cytopenias or pancytopenia. Prevention is by using irradiated blood products, which destroys the T lymphocytes in the transfusates. The diagnosis of GVHD is often challenging because the symptoms are and it mimics many other similar diseases like viral infections, drug reactions, autoimmune conditions, liver failure, aplastic anemia. Skin biopsy would lymphocytic infiltration with epithelial damage and necrosis in the skin biopsy. PCR for WBC chimerism or FISH can be an option for diagnosis. Treatment would be a high-dose corticosteroids. They are often the first line. Some cases, depending on the severity, may require immunosuppressants like cyclosporine, tacrolimus, and ATG. Ruxolitinib for severe GVHD. There is a consideration for emergency allogenic stem cell transplant, but it is practically not feasible because it is time consuming and finding a donor is difficult. As said before, it has a very poor prognosis and the mortality is more than 90%. Coming to the next question would be a hyperviscosity syndrome in the ICU. So a small line about viscosity is mainly a measure of resistance to flow based on the shear stress. That is, it is a measure of the stickiness or the thickness of blood. And hyperviscosity syndrome occurs when the blood viscosity increases sufficiently to impair microcirculation, leading to end organ complications. So you mentioned a few causes for hyperviscosity syndrome. You can divide it into plasma anomalies, increased cellularity, and decreased cell deformability. Plasma anomalies include Waldenstrom's macroglobulinemia, multiple myeloma, and paraproteinemias. And polyclonal gammopathies like cryoglobulinemia or Sjogren syndrome or a rituximab IgM flare. And conditions having an increased cellularity would be polycythemia vera, leukemias, or essential thrombocytosis. And with a decreased cell deformability would be a sickle cell disease. So how does it present to us? It has a classical triad in about 70% of the cases, which is mucosal hemorrhages, neurological features, and visual disturbances. There can be high output cardiac failure or there can be pulmonary edema associated with it. So diagnosis would be assessing for erythrocytosis, hyperleukocytosis, thrombocytosis, looking for blasts and abnormal cells, Role formation in the peripheral smear. Protein assays, a total protein of more than 100 often suggests paraproteinemias. Reversal of AG ratio is also a clue. The direct evidence would be by measurement of a viscosity by something called as an Ostwald's viscometer. The normal viscosity would be about 1.4 to 1.8 centipoise. And if the viscosity is more than 3, it gives us a suggestion of hyperviscosity syndrome. And for leukemia and lymphoma, you can go with a bone marrow biopsy or flow cytometry. So, what is hyperleukocytosis? It is a WBC count greater than 1 lakh cells per microliter. It is different from leukostasis. Leukostasis is an oncologic emergency characterized by extremely high WBC counts in the cell that results in impaired tissue perfusion and subsequent end organ damage. There is no defined at which leukostasis will occur because it can be seen in as low as 50,000 cells. The type of leukemic cells present is a far more important factor, as we can see in this picture. Hyperleukocytosis can be seen in both myeloid leukemias and lymphoid leukemias, whereas leukostasis is seen more in myeloid leukemias and very rarely seen in lymphoblastic leukemias. Again, clinically, it's mainly neurological in 40% of the patients, seizures, focal deficits, visual changes, mental status changes. There is a risk for intracranial hemorrhage if DIC and thrombocytopenia are present. And the second would be respiratory in about 30% of the patients. Dyspnea and hypoxemia. Imaging reveals interstitial or alveolar infiltrates. So how do you manage hyperviscosity syndromes? The general management would be airway, breathing, circulation, symptom-directed care like seizures, benzodiazepines, vasopressors if hypotensive. The treatment of choice would be emergency therapeutic plasma exchange. TP is the standard of care for hyperviscosity. You do not delay for any definitive diagnosis. You start TP within 6 hours of suspicion. You remove 1 to 1.5 plasma volumes per session. You replace with normal saline or 5% albumin. And you remove approximately 25% of the patient's plasma volume per session. You start TP when you have a clinical triad, as we had seen before, mucosal hemorrhages, neurological features, and visual disturbances. Or when the serum viscosity is more than 4 centipoise, if you have CNS symptoms along with paraproteinemia, or if you have visual changes along with retinal findings. Like in MI, like in stroke, time is tissue in hyperviscosity syndrome. And in those where you do not have a facility for plasmapheresis, we can go with a judicious phlebotomy with crystalloid or blood product replacement as a temporizing measure. And depending on the etiology, you can use different apheresis techniques. For immunoglobulins, you do a plasmapheresis. For leukostasis, you do a leukapheresis. Thrombocytosis, you can do a platelet pheresis. And for polycythemia, you do a phlebotomy. And there are certain adjunctive measures in hyperviscosity syndrome. Immediate measures include hydration with normal saline and platelets if there is severe thrombocytopenia with bleeding. Intermediate measures, 24 to 72 hours, you can go with a cytoreactive chemotherapy for the underlying malignancy. For Waldenstrom's, you can go with rituximab, and for leukostasis, hydroxyurea to reduce the cell count. And long term would be disease-specific treatment protocols as per the cause. And if refractory to chemotherapy, some cases will need a maintenance therapeutic plasma exchange for long. Coming to the next question would be again a divided question. The first would be CAR T cell therapy in ICU, and the second would be a checkpoint inhibitors in the ICU. So what is CAR T cell therapy? It is a novel autologous cellular therapy where the patient's T cells are engineered ex vivo outside with a recombinant T cell receptor or a chimeric antigen receptor. And this mediates antibody targeted recognition in a MHC independent manner. This line is important in the examination, MHC independent manner. Because what normally happens is the T cells, they kill the cancer cells via MHC. And the cancer cells, they have a mechanism by which they downregulate the MHC and they acquire resistance to the T cell activity, and the T cell activity goes down. And CAR T cell, they enhances the T cell activity by bypassing this tumor evasion strategies like MHC downregulation. So this is the steps of how a CAR T cell therapy occurs. The first step would be collection of T cells from the patient's blood by leukapheresis. And this T cells is genetically modified by a viral vector or a non-viral vector by CRISPR-Cas9 mechanisms. And once a genetically modified CAR T cell, they are multiplied outside and again they are reinfused back into the patient's bloodstream. And prior to reinfusion, the patient has something called as a lymphodepletion chemotherapy by using fludarabine or cyclophosphamide. And after lymphodepletion, the CAR T cells are infused into the patient. And once the CAR T cells are infused, the CAR T cells, they identify the cancer cells and they kill the cancer cells because of their chimeric antigen. So what are the indications? Depending on the type of CAR T, the CD19 CAR T, they are used in pediatric and adult ALL, also used in high risk, high grade B cell NHLs like a diffuse large B cell lymphoma, primary mediastinal B cell lymphoma, or an indolent follicular NHL. An anti-BCMA CAR T is used in multiple myeloma. So what are the adverse effects of CAR T? You divide it into short term, medium term, and long term. Short term would be tumor lysis syndrome, infections, sepsis, cytokine release syndrome, something called as the ICANS, the immune effector cell associated neurotoxicity syndrome, or it can lead to a HLH-like syndrome. Medium term, it leads to B cell aplasia, hypogammaglobulinemia, and delayed prolonged cytopenias. And long-term effects include neuropsychiatric issues like any mood disorders or cognitive dysfunction. It can lead to persistent fatigue. So we'll discuss two of these in detail. Coming to the cytokine release syndrome, it is the most common acute adverse event we see after CAR T cell therapy. And it has different gradings. More than grade 2 is seen in about 10 to 30% of the CAR T cell therapy and usually appears within the first 14 days of CAR T infusion in most cases. The risk factors include tumor burden, any active infection, baseline inflammation, the type of the CAR T used and the dose of the CAR T given, and the intensity of the lymphodepletion therapy prior to CAR T infusion. And how does it occur? The effector cytokines which are released by the CAR T cells, they, in addition to killing the tumor cells, they also activate the monocyte macrophage system, leading to the production of pro-inflammatory cytokines, predominantly IL-6. So this is a graphical depiction. You can make out the CAR T cell has its effect on the tumor cells. Along with the effect on the tumor cells, it has a secondary inflammatory response by activating the monocyte and macrophages, leading to the production of IL-6 and the cytokine storm, interleukin 1, interleukin 2, IL-6, IL-8, IFN gamma, and TNF alpha, and eventually leading to endothelial damage. So the grading is given by the ASTCT. There are 4 grades depending on the temperature, hypotension, and hypoxemia. The main thing we need to note here in right in the exam hall is the treatment of choice would be tocilizumab. For grade 2 onwards, tocilizumab IV 8 mg per kg is the treatment of choice, along with dexamethasone 10 mg 6 hourly. And for grade 3, you increase the dose of dexamethasone to 20 mg 6 hourly if tocilizumab fails. And for grade 4, you can step up to methylprednisolone, high dose methylprednisolone 1 gram per day for 3 days, day 1 to day 3. And some experimental therapies, if it's refractory to steroids and tocilizumab, would be a siltuximab, that is an anti-IL-6 drug, and anakinra, that is an anti-IL-1 antagonist. Coming to the neurotoxic syndrome, that is an ICANS. It is the second most common adverse event. It can occur with or without CRS. It is seen in about 12 to 30% of all cases and appears between 3 to 7 days after CAR T therapy. Clinically, we can make out tremors, myoclonus, altered mentation, dysarthria, and seizures. Risk factors are the same as those for the cytokine release syndrome, and the mechanism is mainly due to endothelial activation and collapse of the blood-brain barrier, which leads to the migration of these immune cells into the CNS. Again, it has 4 grades depending on the ICE score, the immune effector cell encephalopathy score. And as for CRS, the drug of choice is always tocilizumab along with steroids, dexamethasone, methylprednisolone, and if refractory, anakinra and siltuximab are the other options. Coming to the next topic, checkpoint inhibitors in intensive care. So what are these checkpoint inhibitors? The immune system has a innate natural checkpoints to regulate the uncontrolled T cell activity. 2 of the important checkpoints are something called a CTLA4, the cytotoxic T lymphocyte antigen 4, which are expressed on the T cells and the Treg cells, and they actually compete with CD28, blocking the co-stimulation, leading to T cell energy. We'll see it in the next slide. And the second checkpoint would be PD1, something called a program death 1, expressed on the effector T cells in the peripheral tissue. It binds to PDL1 on the tumor cells, leading to T cell exhaustion. And what happens in cancer is the tumors often upregulate these checkpoints to suppress the cytotoxic T cells, and they create an immune privileged niche for themselves and thereby escapes the immune surveillance of the body. And what do the checkpoint inhibitors do? They actually remove these checkpoints given by the tumor cells and they unleash the anti-tumor cytotoxicity, at the same time also causing off-target autoinflammation due to excessive immune activation. So this again a graphical depiction. As you can make out, this is the PD1 and the PDL1 interaction, which leads to depletion of the T cell. And the second checkpoint would be the CTLA4, which actually competes with the CD28 and leading to T cell exhaustion. And these are the targets which are given by the checkpoint inhibitors. The anti-CTLA4 would be ipilimumab. The PD1 antagonist would be a pembrolizumab, nivolumab, and cemiplimab. And the anti-PD-L1 drugs would be atezolizumab, avelumab, and durvalumab. So where are these checkpoint inhibitors used? The anti-PD1 checkpoints are used in melanoma, non-small cell lung cancer, Hodgkin's lymphoma, urothelial cancers, RCC, metastatic colorectal cancers, and also in head and neck cancers. Anti-PD-L1 checkpoints, the atezolizumab and durvalumab, they are used in again non-small cell lung cancers, urothelial cancers, and also in triple negative breast cancer. And anti-CTLA4 is used in melanomas. So what are the adverse effects due to the checkpoint inhibitors? Again, these are mainly due to autoimmune activity. Because the natural checkpoint is released, again, in addition to the tumor cells, they attack the normal tissues of the body. And as we can see here, almost every system in the body is involved. The few of the important ones are skin, which is the most common. It can be as severe as Stevens-Johnson syndrome and toxic abdominal necrolysis. Lungs, pneumonitis, and ILD is the common side effect of nivolumab. GIT is the most common and most debilitating side effect of checkpoint inhibitors, colitis, ileitis, pancreatitis, and gastritis. It can lead to myocarditis, pericarditis, and vasculitis. And in the CNS, it can lead to a Guillain-Barré syndrome-like syndrome or encephalitis, meningitis, and a myasthenia gravis-like syndrome. And management of these adverse effects, again, you can look at the slide later. But again, the thing to note in the exam is, as always, the treatment of choice would be steroids. If it's a grade 1 and grade 2, you go with a oral steroid therapy. For higher grades, you go with a high dose steroid therapy. And coming to my last question, this is a straightforward question. Immunosuppressants, their drug modifications, drug-drug interactions, and adverse effects and contraindications. So coming to immunosuppressive therapy, the type of drugs we give depends on the specific transplant which is occurring. In most cases, a CNI, calcineurin inhibitor like a cyclosporine or tacrolimus, forms the backbone. And the CNI is usually combined along with an additional anti-proliferative drug like a mycophenolate or azathioprine, or with an mTOR inhibitor like everolimus or sirolimus, along with glucocorticoids. And before starting immunosuppressants, patients often receive induction therapy to deplete the T cells, which could be either with an interleukin 2 blocker like a basiliximab or a T lymphocyte depleting therapy ATG or alemtuzumab. And again, this is a straightforward table. You can have a detailed look at it later. Depending on the hepatic dysfunction and renal dysfunction, how do we modify the calcium inhibitors, azathioprine, mycophenolate, and mTOR? I'll just be skipping this part. And these are this table which describes the drug interactions along with common antimicrobials. You can also look at it later. So what is important is the adverse effects. You can divide the adverse effects into non-infectious adverse effects and infectious adverse effects. You will mention about the nephrotoxicity because of calcineurin inhibitors mainly occurs due to vasoconstrictor effect on the afferent arteriole, leading to GFR reduction. There can be an acute nephrotoxicity leading to tubulotoxicity and sodium and water retention, or there can be a chronic nephrotoxic reaction leading to interstitial fibrosis and nephritis. Hypertension is a side effect, again more with calcineurin inhibitors because of the vasoconstrictor effect on the afferent arteriole. De novo diabetes mellitus is seen in 20 to 40% of all transplants, and the incidence is higher with tacrolimus, again due to decreased insulin signaling and beta cell dysfunction. Thrombotic microangiopathy is an adverse effect because of the disruption of the normal endothelial epithelium. Neurotoxic features like tremors, seizures, cortical blindness, and PRES can be seen. The pathophysiology of how this occurs is still unknown. Myelosuppression is seen with azathioprine, mycophenolate mofetil, and mTOR inhibitors because of the inhibition of the enzyme inosine monophosphate dehydrogenase, which leads to inhibition of the nucleotide synthesis. Cyclosporine also causes hirsutism, acne, and gingival hyperplasia. GI effects are seen more with azathioprine and MMF, diarrhea, gastritis, hepatotoxicity, and these can be dose limiting. Malignancy is a side effect, can lead to PTLD, post-transplant lymphoproliferative disorder. It can also lead to skin cancers. With mTOR inhibitors like sirolimus and everolimus, interstitial pneumonitis is a concern. And hyperlipidemia and hypertriglyceridemia are also seen with CNIs and mTOR inhibitors. And coming to the infectious complications, you can divide it into less than 1 month, 1 to 6 months, and more than 6 months. In the less than 1 month period, it is mainly healthcare associated infections, which can be due to surgical site, WAP, CORTI, CRBSI, Clostridium difficile, or anastomotic leaks. And the organisms involved are mainly gram negatives like Klebsiella, Acinetobacter, Pseudomonas, gram positives like MRSA and VRE. Donor-derived HSV can be seen in the less than 1 month period, and non-albicans candidal infections are common. In the 1 to 6 months period, the healthcare infections, they start to go down, and the opportunistic infections, they start to increase. and it depends on whether the patient is on PCP and antiviral prophylaxis or not. If he's already on prophylaxis, nocardia, legionella, toxoplasmosis, Mycobacterium tuberculosis, aspergillus and mucor is very common. And without prophylaxis, pneumocystis jirovecii and herpes virus infection like CMV, HSV and varicella are very common. And in the period of more than 6 months, it is mainly community acquired. Could be a community acquired pneumonia or UTI. Some late viral infections are also seen in this period. Could be Epstein-Barr virus, CMV, hepatitis virus, hepatitis like HBV and HCV, or atypical mycobacteria. And coming to the last part, contraindications for these immunosuppressive drugs. As for all drugs, hypersensitivity is a universal contraindication, and pregnancy and breastfeeding form a universal contraindication for all these drugs. In addition to these drugs, some things are specific for CNIs, uncontrolled hypertension, uncontrolled diabetes, untreated active infections, and any known malignancy. For azathioprine, if there is a homozygous TPMT deficiency, TPMT is the enzyme which actually metabolizes azathioprine. And if the enzyme is deficient, it leads to risk of fatal myelosuppression. And for MMF, mainly GI. The GI symptoms are the contraindications. Severe cytopenias are also a contraindication for mycophenolate mofetil. And hepatic impairment is a contraindication for mTOR inhibitors. I'll end this point. Thank you.
So I think Dr. Dilip has make excellent presentation. Thank you, Dr. Dilip. And just a few points I'd like to add in the presentation that yes, the students may feel that we will not be able to reproduce the whole thing, whole presentation, whole the topic, and that is not the purpose. The idea is to share you the maximum information that is there. But whenever you are try to write any short note related to any disease, I'll just suggest some subheadings like try to break it down into definition, pathophysiology, risk factor, types and classification, what is the clinical presentation, any scoring system you are aware, diagnosis and management. So even if you write 2-3 lines related to all these things, then it will at least easily cover a five mark question, maybe more than that. That's the first point, because whenever we are giving an exam, we are not going to prepare 10 questions. We are going to prepare 300, 400 short notes. So it's not possible to remember everything, at least for me. And second is that we try to give a certain topics which are most important related to this genre. But when we are preparing, we need to cover lateral topics also. Like for example, we discuss about trally and taco, which are the transfusion related complications. At the same time, what we can do, we can read about mismatch blood transfusion. We can look for non-immunological complications related to transfusion, and we can look for granulocyte transfusion and hemato-oncology and transplant patients. So these are just for an example that this is a way you have to expand your questions. A certain part has been developed. These are some background questions, backbone questions have been shared by Dr. Arindam, and you have to go beyond it. So by this, I like to introduce our second speaker. I think Dr. Maniraj. He's a consultant in the Koveri Hospital, Trichy. He's a DRMB critical care. And over to Dr. Maniraj. You can share your slides.
But I must say one thing, Sudipta and Saurabh. Our last speaker, Dilip, I'm very. I was writing to Saurabh itself that he has really done well. Excellent
Yes,
presentation, and
we are
I must
I
congratulate him.
myself and Saurabh also discussing the same thing. He presented very well. Congratulations.
Thank you, Dilip.
Thank you, sir.
Well done, Dilip. Well done. Yeah.
So over to Dr. Maniraj.
Is my slide visible? Good evening, everyone.
Yeah, our slide is visible. You can make it full screen and start. Yeah.
Okay, sir. Good evening, everyone. I will be discussing 4 questions: thrombocytopenia, febrile neutropenia, DOACs, and hemolysis syndrome. First question is thrombocytopenia. Overview, a brief introduction followed by structured approach to thrombocytopenia, and a little bit about heparin-induced thrombocytopenia and drug-induced thrombocytopenia, and platelet transfusions and indications. So introduction, platelets, they are formed from megakaryocytes. It's a non-nucleated small oval-shaped cell with a lifespan of around 7 to 10 days. And the platelet count normal ranges between 1.5 to 4.5 lakhs. It is maintained in a steady state between bone marrow production and the clearance by liver and spleen. Main functions of platelet, first one is primary hemostasis. We know platelet gets attached to the damaged endothelial cells, followed by activation and platelet aggregation, resulting in the formation of clot. Primary hemostasis is the main function of platelet, followed by immunomodulatory effects. It plays an important role in chemotaxis of neutrophils and formation of neutrophil extracellular traps. And platelet, it also gets activated in various thrombotic mechanisms. Definition of thrombocytopenia, it is defined as a platelet count less than 1.5 lakh per ml, or a relative decrease in platelet count by 30 to 50% irrespective of the platelet count range. So mechanism of thrombocytopenia, three important mechanisms: decreased production, increased destruction, and sequestration. So decreased production, the main causes are aplastic anemia, hematological malignancies, lymphoma, leukemia, myelodysplasia, and metastatic malignancies. Nutritional deficiency like B12, folic acid deficiency, drug-induced thrombocytopenia, and viral infections like HIV, mumps, parvovirus, varicella, Epstein-Barr virus, etc. And increased destruction, it is mainly divided into immunological and non-immunological. Immunological causes ITP, HIT, drug-induced thrombocytopenia, APLA, and HIV. Non-immunological causes, we have DIC, HUS, TTP, HELP syndrome, pre-eclampsia, eclampsia, sepsis, and massive bleeding. These topics will be discussed in the next session. And next cause is increased sequestration. It is due to hypersplenism from any cause like cirrhosis, portal hypertension, congestive heart failure, lipid storage disorders, hematological malignancy. Another cause of thrombocytopenia is dilutional thrombocytopenia, mainly due to crystallite resuscitation and transfusion of platelet-less blood products, resulting in dilutional thrombocytopenia. So, approach to thrombocytopenia. First, we have to differentiate thrombocytopenia from spurious thrombocytopenia and pseudothrombocytopenia. Spurious thrombocytopenia, it is due to inadequate anticoagulation in the test tube, like inadequate EDTA, resulting in ex vivo platelet aggregation. So that is spurious thrombocytopenia. Next one is pseudothrombocytopenia. Pseudothrombocytopenia, it is due to ED-induced platelet aggregation. So if you are the first most important it points towards hereditary thrombocytopenia. So in peripheral smear, with thrombocytopenia, you are seeing cystocytes. So cystocytes are what? These are fragmented RBCs. So damage to the RBCs that occurs while the RBC is traversing through the microcirculation. This usually occurs in thrombotic conditions, thrombotic microangiopathy. So thrombocytopenia along with cystocytes, look out for TTP, HUS, and DIC, and proceed with investigations for these things like LDH, bilirubin, haptoglobin, coagulation profile, D-dimer, fibrinogen. And in next one is thrombocytopenia with blast cells or nucleated RBCs or dacrocytes, tear-shaped WBCs you are seeing. Then it points towards mainly bone marrow disorder. You have to go for bone marrow biopsy. So next thing is, if there's a thrombocytopenia with RBC clumping or agglutination, it indicates there is an autoimmune disorder affecting RBC along with platelet count and maybe WBC also. So rule out Evans syndrome, and you have to proceed with the Coombs test, reticulocytes, LDH, and bilirubin. If there is a lymphocytes or toxic granules or neutrophilia in the peripheral smear, consider infection, proceed with infective panel workup. And if there is only isolated thrombocytopenia, consider ITP, drug-induced thrombocytopenia, heparin-induced thrombocytopenia, and other infections. And investigation should be based on the clinical scenario. So most important thing is peripheral smear. Based on the peripheral smear, you have to proceed with the investigations. So Next thing is heparin-induced thrombocytopenia and thrombosis. The pathophysiology is heparin. It is a negatively charged polysaccharide, and it binds with the positively charged molecule called platelet factor 4, which is released from platelets. So this complex heparin and platelet factor 4, it is recognized by the immune cells, and there is a production of antibody against this heparin and platelet factor 4 complex. This antibody binds to the FCR segment of the platelet, resulting in activation and aggregation of platelets, leading to consumption of platelets. So this results in thrombocytopenia and thrombosis. So signs and symptoms: thrombocytopenia fall by more than 50%, occurring days of 5 to 10 after heparin exposure, and thrombosis, venous, arterial, and microthrombosis. So whenever you are suspecting 4T, we have two scoring systems. One is our 4T scoring system, another is HEP scoring system, hit expert probable scoring system. We are commonly using 4T scoring system. So you are using heparin and there's a drop in platelet count. So first you have to see is whether the hit probability is high or not. Do the 4T scoring system. So there are 4 important T's. First one is thrombocytopenia. Next one is timing of onset of thrombocytopenia. Third is thrombosis. And fourth is other causes of thrombocytopenia. So thrombocytopenia, if the decrease in platelet count is more than 50% and the lowest platelet count is about 20,000, it corresponds to a point of 2. Point 1 is 30 to 50% platelet decrease, and the lowest platelet is between 10 to 90. And 0 is less than 30% of platelet decrease, and the platelet count is less than 10,000. So if the platelet count is less than 10,000, it is unlikely that it might be a hit. Okay. So next one is timing of onset. Days 5 to 10, there is a high possibility that it is a hit, corresponds to a score of 2. Or thrombocytopenia within 1 day with the previous exposure of heparin in the last 30 days. Next one is thrombocytopenia occurring after 10 days, or thrombocytopenia occurring within a day with the previous exposure of heparin in 31 to 100 days. 0 is thrombocytopenia occurring within 4 days. So thrombocytopenia within 4 days, unlikely it is going to be a hit. Next one is thrombosis, proven new thrombosis, and there is a skin necrosis, corresponds to a point of 2. And there is a progressive recurrent thrombosis or skin lesions corresponding to point of 1. And no thrombosis is 0 point. And fourth one is other causes of thrombocytopenia. So if there are no other causes of thrombocytopenia, it corresponds to a point of 2. So overall hit probability, if the score comes between 6 to 8, it is a high probability of heparin-induced thrombocytopenia. 4 to 5 intermediate, 0 to 3 low. So I am having my patient is having thrombocytopenia with heparin exposure, and if the hit probability score is low, I don't need to stop heparin. I can continue heparin. If the hit probability is intermediate or high, I stop heparin. And for further confirmation, we have to do an enzyme immunoassay. And if the enzyme immunoassay is positive, then you have to proceed with platelet functional assay. Platelet functional assay is the gold standard, and it is the confirmatory test for it. So management of heparin-induced thrombocytopenia, you have to use non-heparin anticoagulation. If there is an apparent thrombosis, you have to give anticoagulation for 3 to 6 months. So if there is no thrombosis, you have to give anticoagulation till the platelet count recovers. So alternatives to heparin, we have direct oral anticoagulants like ergotraben, rivaroxaban, apixaban, warfarin, fondaparinux, and danapride. So next one is drug-induced thrombocytopenia. The mechanism of drug-induced thrombocytopenia is immunological and non-immunological. Immunological is antibody-mediated, like heparin-induced thrombocytopenia. Non-immunological, it is mainly due to cytotoxic effects of the drugs on megakaryocytes and platelets. And also another mechanism is pro-apoptotic effect. It induces calcium channel signaling, mitochondrial depolarization, resulting in apoptosis of the platelets. These are some of the drugs associated with thrombocytopenia. Important drugs that we routinely use: linezolid, vancomycin, and methotrexate we should remember. Then coming to management of thrombocytopenia, we have to see the bleeding risk. So we have modified WHO bleeding scale. 4 grades are there. Grade 1 is minor hemorrhage, grade 2 is moderate hemorrhage, grade 3 is major hemorrhage, grade 4 is severe hemorrhage. And the bleeding risk assessment, so based on patient factors like advanced age, recent history of bleeding, associated organ failures like renal failure, liver failure, or multiple organ failures, and treatment procedures. Are we giving anticoagulations, antiplatelets, or are we planning for any invasive procedures? And biology. Usually, the etiology of thrombocytopenia is associated with the bleeding risk, like hypoproliferative thrombocytopenia is associated with more chances of bleeding than peripheral causes of thrombocytopenia, and the lowest platelet count and the refractoriness to platelet transfusion and associated hemostasis disorders. So based on the bleeding risk assessment, we plan for platelet transfusion. So platelet transfusion can be categorized into 4 categories. First one is prophylactic platelet transfusion, when the platelet count is very low and there is a high risk for bleeding. Next one is pre-procedural transfusion, planning for any procedure, and we are transfusing platelets. We have certain cutoffs for that. Third one is therapeutic platelet transfusion for bleeding, and fourth one is no platelet transfusion. Certain conditions, despite the platelet count being low, we intend not to transfuse platelets, like in conditions like thrombotic microangiopathies and ITPs and the reversal of antiplatelet agents in intracranial hemorrhage. So, moving on to next question, febrile neutropenia. Febrile neutropenia overview, definition, risk assessment, and empirical antimicrobial regimens. So first definition, neutropenia is defined as a absolute neutrophil count of less than 1,500 cells per ml. Profound neutropenia is absolute neutrophil count less than 100. Prolonged or protracted neutropenia is ANC less than 500 for more than 7 days. Febrile neutropenia definition is a single temperature measurement of more than 38.5 degrees Celsius or a sustained temperature of more than 38 degrees Celsius for an hour in a patient with ANC count of less than 500 or ANC count less than 1,000, which is expected to drop to 500 over subsequent 48 hours. Pathophysiology, chemotherapy causes bone marrow suppression, which weakens the body's immune response. Chemotherapy also results in barrier disruption, leading to damage of mucosal lining, mucositis, resulting in bacterial translocation. And because of neutropenia, there will be limited neutrophil response, which reduces the signs of infection. So often fever is the only sign of infection we have in neutropenic patients. The most common pathogens involved are gram-positive bacilli, gram-negative bacteria, candida, and aspergillus. Sometimes, despite neutrophil count being low, there is extensive cytokine release leading to sepsis, shock, and multi-organ failure. So, risk assessment, we have 2 scoring systems, MAC scoring system and Succext scoring system. MAC, 7 variables are there. Total score is 26. Lower the score, higher the risk. MAC score less than 21, it comes under high risk. High risk patient needs to be admitted in ward, admitted either in ward or ICU based on the clinical condition and managed. Another next score is Succext scoring system. 4 variables, score more than 3 is high risk. So assessment, in a patient with neutropenia, note the presence of indwelling invasive catheters. Look for any symptoms or signs suggesting any infection focus from respiratory system, gastrointestinal system, urogenital system, central nervous system, central nervous system, and oropharynx and skin. So get a record of any previous positive microbiology records and investigation. Take blood culture from periphery site and pre-existing intravascular devices before administering antibiotics, and do a complete blood count, renal function test, liver function test, coagulation profile, CRP, and lactates. If clinically indicated, proceed with chest X-ray, URI, LRI panels, sputum culture, stool culture, bacterial swab of lesions, CT chest, bronchoalveolar lavage, CT brain, and lumbar puncture. Organisms of primary concern is gram-negative bacilli, coagulous negative staphylococcus because of indwelling catheters, staphylococcus aureus, streptococcus viridans, and resistant organisms like MRSA, VRE, ESBL, Pseudomonas, Stenotrophomonas, Acinetobacter, and fungal infections. Because of the indwelling catheters and use of fluoroquine prophylaxis in chemotherapy patients, there is an increased gram-positive infection predominance. Any patient with the febrile neutropenia, based on the MAC scoring system, assess them into either high risk or low risk. Low risk patients can be managed in OPD basis. High risk patients start with empirical antibiotics. Empirical antibiotics should include anti-pseudomonal beta-lactams. And if the patient is having high risk for MRSA, like intravascular device, or patient is having hemodynamic instability or previous history of colonization with MRSA organisms, add vancomycin 15 to 20 mg per kg in 2 to 3 divided doses. So initiate anti-pseudomonal antibiotics plus MRSA coverage and reassess the patient. After 72 to 96 hours, patient remains afebrile, and you have got your microbiological report. And if the microbiological report is having is growing organism, and antibiotic target the organism by antibiotic tailoring. If there is no infection identified, and if the patient is afebrile, you can consider de-escalation of the antibiotics. There are different guidelines. Usually, ESMO recommends de-escalation to fluoroquinolones and then tapering. And after 72 to 96 away, the patient is hemodynamically unstable and patient remains febrile, consider echinocandidates. So overview, first line is anti-pseudomonal beta-lactam antibiotic. Add vancomycin to and if the antibiotic also 4 of CP2 so moving on to next question. Direct oral anticoagulants. We'll be discussing about mechanism, pharmacokinetics, and clinical trial evidence, indications, contraindications, and reversal agents. So oral anticoagulants that are available are vitamin K and antagonist or warfarin. Direct oral anticoagulants includes direct thrombin inhibitors, dabigatran, argotraban, factor 10A inhibitors like rivaroxaban, apixaban, etoxaban, and betrixaban. So mechanism of action. So we have extrinsic pathway, both culminate into common pathway. Common pathways begins with activation of factor 10 to factor 10A, which further activates thrombin to thrombin. Thrombin converts fibrinogen to fibrin monomer, which gets which upon which upon activating with factor 13 forms fibrin polymer. So factor 10A inhibitor rivaroxaban inhibits the conversion of factor 10 to 10A, and direct thrombin inhibitors inhibits the conversion of prothrombin to thrombin. So mechanism of action, rivaroxaban, apixaban, it causes selective reversible inhibition of free factor 10A or clot-bound factor 10A, which inhibits, it also inhibits the thrombin-induced platelet aggregation. Direct thrombin inhibitors, reversible inhibition of free or clot-bound thrombin. Dabigatran, it is a prodrug which gets metabolized into an active compound, dabigatran, by enzymes in plasma and liver. So half-life, apixaban is around 8 to 15 hours, and it takes 1.5 to 3 days after the last dose to be completely free of the drug effect. Rivaroxaban 5 to 9 hours is the half-life. Etoxaban 6 to 11 hours. Dabigatran 12 to 17 hours. So clinical trials, For DOACs, in atrial fibrillation, we have three important trials: Relay, Rocket AF, and Aristotle. So Relay is for dabigatran. Inferences: dabigatran 150 mg is superior to warfarin in preventing embolic stroke, and it is equivalent to warfarin in bleeding complications. Dabigatran 110 mg is equivalent to warfarin in preventing embolic complications and superior in bleeding complications compared to warfarin. Both doses are associated with less intracranial hemorrhage compared to warfarin. However, there is a high incidence of GI bleed when compared to warfarin. Next one is Rocket AF. It is rivaroxaban 20 mg OD compared to warfarin. It is non-inferior in preventing embolic stroke, and there is less incidence of intracranial and fatal hemorrhage. However, there was more GI bleed incidence. Next is Aristotle. For apixaban 5 mg BD, it is superior to warfarin in preventing embolic stroke, and the incidence of GI bleed is also equivalent to warfarin, and the overall mortality was lower in apixaban group. So highlight is all the NOACs are either as good or superior to warfarin in preventing embolic stroke. The incidence of ICH is low. However, there is a high incidence of GI bleed when compared to warfarin. Then clinical trials of DOAC in DVT and pulmonary embolism, Einstein DVT and Einstein pulmonary embolism. Rivaroxaban 15 mg BD for 3 weeks followed by 20 mg OD compared to enoxaparin BD for 5 days followed by warfarin maintenance. Primary outcome is symptomatic recurrent VTE. Rivaroxaban was non-inferior to warfarin in treatment recurrence, and there was no increased bleeding risk. It is safe to switch to rivaroxaban after initial treatment with enoxaparin or heparin. So comparative pharmacology, the important thing is uh, renal clearance. We can see dabigatran has a 80% renal clearance. That means whenever we are having a bleeding associated with dabigatran, dialysis might help in controlling the bleeding. And bioavailability of dabigatran is only 6%, whereas bioavailability of rivaroxaban and apixaban is 80 to 60%. Choosing among the NOC agents, if the creatinine clearance is between 30 to 50, rivaroxaban and apixaban are a safer drug, as dabigatran is predominantly excreted by kidney. And for ischemic stroke and warfarin, dabigatran is preferred. And patients with UGI bleed, apixaban and rivaroxaban are preferred compared to dabigatran. And recent GI bleed, apixaban is preferred. Significant CID, apixaban or rivaroxaban are preferred. There is a recent evidence of myocardial infarction associated with dabigatran. Dose modification, dabigatran, it is 150 mg BD. If the creatinine clearance is 15 to 30, dose is 75 mg BD. Rivaroxaban standard dose is 20 mg once a day. If the creatinine clearance is 15 to 30, dose should be reduced to 15 mg OD. Apixaban 5 mg BD. And if the creatinine is more than 1.5, weight less than 60 or age more than 80 years, dose should be reduced to 2.5 mg BD. Reversal of DOACs. For dabigatran, we have idarizumab. It is a monoclonal antigen that binds with dabigatran. It has a very high affinity for dabigatran compared to thrombin. Affinity is more than 350 times. Dose is 5 gram. It has a half-life of 45 minutes. For factor 10A inhibitors, we have antisenate alpha. It is a modified recombinant inactive form of factor 10A protein. It binds and sequesters to factor 10A inhibitors. Half-life is around 1 hour. Dose, we have low dose regimen and high dose regimen. Low dose regimen is 400 mg IV bolus at a rate of 30 mg per minute, followed by 4 infusion of 4 mg per minute. High dose regimen is 800 mg IV bolus, followed by an IV infusion of 8 mg per minute. We have a new reversal agent called siraparantan. It causes reversal of all anticoagulants like heparin, low molecular weight heparin, DOACs, and phase 1 and phase 2 trial has been completed. Dose is around 100 to 300 mg. Post-reversal complications, thrombotic events, there are reported events of thrombosis and incomplete reversal. So next question is tumor lysis syndrome. So tumor lysis syndrome, it is an oncological emergency. It can occur either spontaneously or after anti-neoplastic therapy, mainly after initiating chemotherapy or targeted immunotherapies, corticosteroids or radiotherapy or chemoembolization. It is classified into two categories, laboratory TLS and clinical TLS. The classification is Cairo-Bishop classification. Laboratory TLS is uric acid more than 8, potassium more than 6, or phosphorus more than 4.5, or calcium less than 7, or a 25% increase from the baseline. For calcium, 25% decrease from the baseline. So this is laboratory TLS. Along with the laboratory TLS, if the patient is having a creatinine of more than 1.5 times the upper limit, or cardiac arrhythmias, seizures, or sudden death, it is clinical TLS. So pathogenesis, whenever there is a breakdown of tumor cells, there is going to be release of phosphates. So this phosphates combines with calcium, resulting in precipitation of this calcium phosphate in kidneys. And another thing is whenever there's breakdown of tumor cells, there is a release of nucleic acids, resulting in hyperuricemia. Hyperuricemia, it causes both precipitation in the kidneys as well as it causes vasoconstriction, impaired autoregulation, indirectly resulting in acute kidney injury. There is also a release of inflammatory mediators, resulting in organ dysfunction. So risk factors for TLS, tumor risk factors and patient-related risk factors. Tumor risk factors, type of tumor, if the tumor volume is more than 10 centimeter with metastatic disease, high tumor growth rate, LDH more than 2 times the normal value, leukocytosis, TLC count more than 25,000, and highly sensitive tumors to chemotherapy. These are the risk factors for TLS. And patient-related risk factors like male gender, age more than 65, creatinine more than 1.4, pre-treatment uric acid is more than 7.5, associated conditions like hypotension, hypovolemia, and nephrotoxic drugs. So management, identify the high at-risk patients and initiate prophylaxis. The goal is to maintain adequate urine output and to decrease the level of uric acid, potassium, and phosphate. Monitoring, at high-risk patients, monitoring is 4th to 6th early, intermediate risk patients 8 to 12 early, and for low-risk patients, daily monitoring of TLS parameters. And you have to avoid nephrotoxic drugs, AC inhibitors, and AR blockers. Management, most important important aspect in management is volume expansion. By crystallite solutions, increase the urine output, thereby increasing the phosphate, potassium, and uric acid excretion. Ideally, 2.5 liters, 2.5 to 3 liters in adults, or 200 ml per kg in children. For 2 to 3 days before initiating chemotherapy. Urine output achieve a diuresis of 2.5 liters per day or 4 ml per kg per hour in children. Diuretics is routinely not recommended, used only in case of symptomatic hyperolemia. Loop diuretics is preferred. Urine alkalization, it is controversial. It causes conversion of uric acid to urate and decreases the tubular crystal precipitation. However, it causes precipitation of calcium phosphates in the kidney, which might cause AKA. So urine alkalization role is controversial. Management, calcium supplementation. It should be done only in cases of symptomatic hypocalcemia. Routinely, empirically, supplementing calcium might might cause nephrocalcinosis. Hyperkalemia, medical management with beta-2 agonist, J drip, bicarbonate. In refractory hyperkalemia, go for renal replacement therapy. Hyperuricemia, we have allopurinol, which is a xanthine axis inhibitor. Usually, it is oxidized by xanthine oxidase to oxypurinol, which is a competitive inhibitor of xanthine oxidase. It is used in it is used as a prophylactic treatment. Dose is 200 to 400 mg in 1 to 3 doses. So it is allopurinol is started as a prophylactic therapy 24 hours prior to chemotherapy and continued for 7 days. Complications, there was a high incidence of Stevens-Johnson syndrome, TENS, bone marrow aplasia, DRESS syndrome with allopurinol. Alternative is febuxostat. It is associated with less hyposensitivity reaction and doses 120 mg per day. Recently, we have started using raspberry. It is a recombinant variant of urate oxidase. It converts uric acid to allantoin and hydrogen peroxide. This it Production of hydrogen peroxide can cause hemolytic anemia in patients with G6PD deficiency. So before initiating raspberry, it's better to rule out G6PD deficiency in patients. Doses around 0.05 milligram per kg. And recently, latest drugs are oral recombinant urate oxidase. It facilitates intestinal degradation of urate. The drug is pegloticase. It is a recombinant porcine uricase. Next is graft versus host disease. So graft versus host disease, it is the immune response of immunocompetent donor T lymphocytes from the donor graft against the recipient tissues. The donor T cells acts on the recipient tissues, resulting in damage in various organs like these are allogenic bone marrow transplantation, solid transplantation, which are rich in lymphoid cells, and transfusion of non-irradiated blood. Pathophysiology. The donor cytotoxic T cells recognize the host tissue and proliferate to form cytotoxic T cells, which causes organ damage. It is further divided into three phases. So phase one is prior to prior to transplant, during radiation or chemotherapy, there is damage to the recipient tissues, leading to increased levels of cytokines and MHC antigens. These are presented by the antigen presenting cells to the donor T cells. In phase two, there is interaction of donor T cells with the host APCs, resulting in proliferation and differentiation of activated T cells and resulting in further production of inflammatory cytokines. Phase three is these T cells which are activated migrate to the recipient tissues, resulting in organ damage and multi-organ failure. So acute GVHD most commonly affects skin, gastrointestinal tract, and liver. It can also affect lung, kidney, eyes, and hematopoietic system. Skin manifestations are pruritic or a painful maculopapular rush. It might progress to SGS or TENS. GI symptoms: diarrhea and abdominal pain, mucositis. Diarrhea is usually secretory. Initially, watery diarrhea may progress to become bloody diarrhea. Liver, abdominal LFTs, elevated bilirubin and alkaline phosphatase. Coagulopathy and hyperammonemia can occur in severe forms. Chronic GVHD mimics connective tissue disorders like collagen vascular disease and systemic sclerosis. So management is based on the grading of GVHD. GVHD grading is from 1 to 4 based on the systems involved skin, liver, and GI tract. We can go through this grading, and based on this, we have Glucksberg grade. Mild is no liver or GI involvement, skin involvement of grade 1 and 2. Moderate is stage 1 liver involvement or GI involvement, and stage 1 to 3 skin involvement. Severe is stage 2 to 3 skin involvement or liver and GI involvement of stage 2 to 4. So management is immunosuppression, corticosteroids, prednisolone, methylprednisolone to reduce inflammation, calcineurin inhibitors like cyclosporin or tacrolimus in combination with steroids, and other immunosuppressants like mycophenolate mofetil, sirolimus, azathioprine. In refractory cases, anti-thymocyte globulin, TNF inhibitors like infliximab, etanercept, IL-2 receptor antibodies like besliximab, daclizumab can be used. Thank you.
Thank you, Dr. Maniraj.
Thank you, sir.
So I would like to just emphasize, like Dr. Sudipto said, that it is very vast. It is not easy to remember all the 300 questions. Just try to read across the specialities. And when you get a question, try to answer that in a specific manner. Try to give a stepwise answer. try to make some diagram, try to make some flowchart. It will help you make you remember otherwise also. So once you remember through a diagram, through a flowchart, you'll be able to remember the topic in a much easier manner. And if you replicate that in the exam, definitely you will get much higher marks than somebody who's not replicating that in the exam. So that is my takeaway. Anything else from Dr. Sudipto? So move on the last speaker then.
No, I think you mentioned the crux of the point that flowchart and diagrams are best possible way to share information, because when the examiners are going through the copy, they're also exhausted. They are traveling to the center. They're already taken their practical exam in between. They are going through the theory sometimes. In these situations, it is always better to make their life easy. So if you make things very obvious to the face, which they can easily visualized and can mark, and they will get it, that they will understand that you have very good clarity about the topic, rather than writing a big write up, which they have to identify all the salient and important points and then want to give you a mark. Once you make the examiner's life easy, they will definitely give you more liberally in terms of numbers. So I think you are absolutely on the point. And let's continue with the third speaker, I guess.
Yeah, totally agreed. So I would like to welcome Dr. Gurkirat Singh, who's heading the Institute of Neurosciences in Jalandhar, Punjab. Dr. Gurkirat, you can start with your slides, and this is the probably the last part of the last bit of the 2-week program. So over to you, Dr. Gurkirat.
Hi, good evening, sir. Good evening to
You
all
can share
the.
your slides. Yeah.
Yeah. Uh,
I think our previous speaker have to.
yeah, you have to stop sharing so that I can start.
So Maniraj, you have to stop sharing.
It has been done. Now you can
Oh,
share,
yeah.
Dr. Kanil.
Oh, great. Thank you. Thank you.
Yeah.
Great.
Okay, I'm starting. Okay. Hi, my name is Dr. Gurkirat. We are going to start with oncology theory review questions. The plan will be that we are going to discuss these questions in a way that the presenter, those who are writing the exam can know the gist of how to answer, and you have to answer the question in 18 minutes. The biggest problem is that you have to write it in such a way and remember those key points, high yielding points, which are expected from a DM level of a question examiner, that you should know these high yield points. So that's what we are trying to cover. The first question will be ITP versus TTP versus HUS versus HELP. Now, this question will be answered in 3 points. Is asked in 3 parts. What is the pathophysiology, the clinical features, the lab differences, and the management strategies. So to start with the pathophysiology, it will be better to make a table with ITP versus TTP versus HUS versus HELP. You can start by the primary mechanism. The ITP primary mechanism is autoimmune destruction of platelets by antiplatelet antibodies. While the TTP, it is the deficiency of Adamets 13, or there are antibodies to Adamets 13. So because of which there is accumulation of ultra large von Willebrand factor multimers that will cause widespread platelet rich microthrombi and shear injury, causing the microangiopathic hemolytic anemia. Similarly, for HUS, it is more of a endotheliopathy, and HELP, there is more of a endothelial injury. So you should know the how to answer the primary mechanism first of all, because this is a high yield point. In HUS, you have to know that without writing the Shiga toxin, platelet activation, microthrombi activation, and Adamets 13 insufficiency, these are the important points you have to mention, because that is how you're going to differentiate it from ITP, TTP, and HELP, where there is no problem with Adamets 13, or there is no as such autoimmune destruction of platelet, while there the primary mechanism is hemolysis, elevated liver enzyme, low platelet due to placental and trophoblastic invasion. So it is very important to note the gist of the underlying mechanism to differentiate the primary mechanisms. The tumor factor, the tissue factor activity that is created by placental insufficiency causes cytokine release, which causes further endotheliopathy, mimicking just like hemolytic uremic syndrome and TTP. So you have to note the crux in that. Second thing is the Adamets 13 role will help in differentiating whether the ITP, TTP, HUS and HELP syndrome. Secondly, the site of injury is important. The systemic injury is more in TTP, while the renal microvasculature is primarily injured in HUS, while the hepatic injury is more prominent in HELP syndrome. The red cell morphology in ITP versus HUS versus HELP all three will have schistocytes present, while in RBC morphology has got nothing to do with idiopathic thrombocytopenic purpura. Now, the bone marrow findings, you will find more megakaryocytes in ITP, while the bone marrow will be near normal in TTP, HUS, and HELP. The organ involvement, as we have already discussed, it will be primarily more systemic in TTP. In HUS, it will be more of organ failure. Patient will have lower GI bleed, and with that, kidney will be the primary organ taking a hit. Now, the triggering factor we have already discussed that TTP is an Adamets 13 deficiency or antibodies to Adamets 13, while HUS is cause typical Shiga toxin related or a complement dysregulated injury in atypical HUS. Further moving on, these are the same slides, so I'm not going to repeat what I've just said. The clinical features we have already discussed. Now, the second part was labs. So in labs, you have to make a table so that you can have an understanding on how to differentiate all three together. The table will give us an idea that the schistocytes will be there in TTP, HUS, and HELP syndrome, but the schistocytes will not be there in the ITP. The haptoglobin and microvascular injury causing the shear injury will be more in TTP and HUS compared to that in HELP syndrome and ITP. Now, the Coombs test is important to differentiate ITP from TTP, HUS, any kind of microangiopathy, because ITP will be having a positive Coombs test. Now, Adamets 13 is also an important factor which is expected of us to know, because there is going to be deficiency or antibody in TTP, while insufficiency will be there in HUS, while Adamets 13 level is going to be somewhat normal in HELP syndrome. Now, the treatment strategy is that you have to note the primary thing that is expected to be written for high yielding. The primary pathology is autoimmune condition which has to be corrected in ITP. While in TTP, it is a medical emergency, you have to go for plasma exchange. In hemolytic uremic syndrome, if it is an atypical HUS, which we will discuss as the slides progress, we have to rectify the complement problem either by plasma exchange or by using eculizumab. While in HELP syndrome, the primary is the source control, which the delivery of fetus. Now, the treatment modality, the first line treatment for ITP is corticosteroids and IVIG. Second line is rituximab, and there are surgical options also in splenectomy. Similarly, in TTP, the plasma exchange, we will discuss about it in management. And hemolytic uremic syndrome, if it is a primary HUS, then antibiotics, volume, electrolyte, and symptomatic support system has to be given. While dialysis is, as per the guidelines, the HUS, they are coming up with dialysis also. Now, plasma exchange will be there in atypical HUS, and HELP syndrome will be source control. Now, moving on ahead, this is the algorithm we have taken. We have divided the ITP versus TTP versus HUS versus HELP in two parts. If a patient is coming with acute thrombocytopenia, microangiopathic hemolytic anemia, and we are still not sure whether we are dealing with TTP and HUS, first of all, we have to evaluate with the algorithm of creatinine, because that's where if there is a kidney injury with that a GI bleed is there, we can suspect a hemolytic uremic syndrome. And then meanwhile, we can send Adamets 13 levels and start plasma exchange, thinking that we are treating a microangiopathic hemolytic anemia of any phenotype, whether it is TTP, HUS, or AHUS. The standard will be plasma exchange of 1 to 1.5 plasma volume daily for up to 5 cycles. Now, the management will be in three parts: whether the patient is responsive, whether refractory, or whether there is remission. And platelet will be taken as a biomarker here. if after a plasma exchange of 1 to 1.5 plasma volume, platelets are improving, then the response is there. In refractory, there will be suboptimal platelet response, and there the second line treatment will be start coming into the program. And if the ADAMETS 13 level are normal and the patient is having high creatinine and the complement level you have sent and those are coming less, then it qualifies for eculizumab therapy. Now for ITP management, first of all, we have to confirm the diagnosis, whether it is ITP or not. You have to rule out TTP, HUS or any other microangiopathic hemolytic anemia or thrombocytopenic cause with no schistocytes in the peripheral smear and a DCT which is positive. After that, check, assess for the severity and hemodynamic instability and treat the way it is supposed to be with IV methylprednisolone 1 gram per day for 3 days. This we have taken from standard guidelines of ITP management by International Society of Thrombosis and Hemostasis. Now the further, if there is refractory relapse of ITP, you have to go to rituximab, and even thrombopoietin receptor agonist had been suggested by the guidelines, and emergency splenectomy. For HELP syndrome, first of all, we have to confirm the diagnosis using Tennessee and Mississippi criteria, anything with hemolysis, transaminitis, and platelet. With mental stability and other clinical factors can be taken into point. Since it is primarily an endotheliopathy, you have to make sure to keep positive fluid balance with source control. So source control has to be done in precision fluid monitoring so that patient does not land into pulmonary edema. And the timing of delivery is important here. If the patient is more than 34 weeks of gestation, less than 34 weeks, but unstable, less than 34 weeks and stable or postpartum health, the treatment options have somewhat changed. Eventually, after that, the source control is done, the help will move to its status quo. And the further, the differential diagnosis should be considered if patient is not responding. In that situation, the ADAMET 13, the complements and the should be considered. Take the second question. Or we want to discuss the first one.
We can take the second question. Yeah.
Second part and manage. We'll discuss from international and right that the syndrome will coagulation, vascular thrombin and fibrin, resulting in thrombosis of small to medium vessels and ultimately organ dysfunction and severe bleeding. DIC may result as a complication of infection, solid cancer, hematologic malignancy, obstetric disease, trauma, aneurysm, and liver disease. So the DIC concept there is DIC is driven by two coagulation and clinical type of DIC is a vector theory here. Patient could be either on x-axis more of organ failure type of DIC due to coagulation abnormality where there is more consumption of clotting factors and tissue factors which is causing end organ hypoperfusion. So the imbalance between these vectors will result in bleeding, thrombosis, organ failure, massive bleeding, or no symptomatic type of DIC. When vector of hyperfibrinolysis will predominate, patient will have more of hyperfibrinolysis, FDP products will be more, bleeding type of DIC will predominate. When the tissue factors will be more, end organ injury will be there. This is more common in sepsis and in ICU. We will get a hyperphenotype of DIC. When both the vectors of hyperfibrinolysis and hypercoagulation will predominate, as such both physiology coexist in the same time point, then there will be consumption coagulopathy and hyperfibrinolysis occurring at the same time, and patient will have a massive bleeding due to consumptive coagulopathy, which is the classical definition of DIC. Now, the types of DIC, as we have discussed, will be bleeding type, hyperfibrinolysis type, massive bleeding type, and non-symptomatic. And the common one in ICU will be that of sepsis, that is organ failure type. In obstetric emergency, we will find more of a bleeding predominant. Massive bleeding we will find in a major surgery followed by surgical sepsis and non-symptomatic DIC. Now, clinical component, as we have discussed, will depend upon where the vector is sitting of the DIC, whether it will be hyperfibrinolysis or a hypercoagulation defect due to the pathophysiology of tissue factor. So this is the pathophysiology of sepsis-related DIC. I've just taken a minute to make this slide because it has got an intrinsic component on understanding the pathophysiology. The problem will be that there will be increased plasminogen activator inhibitor, increased tissue factor, and cytokinemia with lipopolysaccharides in blood that will cause a state of hypofibrinolysis state. So the vector here, we are on the y-axis and not on the x-axis. So the neutrophil elastase and the tissue factor pathway inhibitor will be more inhibited, and we will see more of end organ hypoperfusion. And HMGB1 has got a role to play in sepsis DIC here. Now, the second part of the question was ISTH scoring system in labs, which is very important for evaluation and management of DIC in ICU. So it has got 4 parts: the platelet count, whether it is more than 100,000, less than 50K, or less or 50 to 100K. And the most important part in this is fibrin degradation product. You can see the 3 score is given to elevated fibrin related markers. So it has got the maximum weightage in ISTH scoring system, because most of the vectors, as the DIC will have be on the x-axis, we will see more of hyperfibrinolysis, and in sepsis patients we will see more on the y-axis vectors, and prolonged prothrombin time and fibrinogen level. And if the interpreted score become more than 5, it is consistent of overt DIC. And the best part of this scoring system is this could be used to diagnose DIC, because when we are in the patient, when we are seeing the patient and we are seeing a constellation of symptoms of prolonged prothrombin time, decreased platelet count, and elevated D dimers and fibrinogen level less than 1 gram, then we get the diagnosis of DIC, and ISTH scoring system gives it a very high interpretation of more than 5 with sensitivity and specificity of around 94%. Now, the lab parameters also vary depending on different types of DIC, but there are some ways to remember this table. The prothrombin time will be increased in all type of DIC. Fibrin degradation products will be decreased in all type of DIC other than the organ failure. So you need to have understanding of the core concept of the vectors of DIC. The platelet count will be decreased in all type of DIC. The Adamets 13 will have insufficiency in organ failure type DIC, while Adamets 13 does not have a role to play in other kind of DIC situations. While fibrinogen will be decreased in all kind of DIC, and antithrombin 3 will be decreased in organ failure type DIC, while it will be while von Willebrand factor will be increased in organ failure type, causing more microangiopathic hemolytic anemia and more of the large von Willebrand factor causing insufficiency related shear injury that we see in other kind of like MAHA phenotypes also. Von Willebrand factor is important to understand that it will have insufficiency in organ failure or sepsis type of DIC. Now, this is the same what I have just explained. It is written in more in a tabulated summary. It is expected of you to write like this in exam, that platelet count will be decreased, APTT is increased, D dimer, von Willebrand factor will be whether insufficient or decreased, and the ROTEM will be variable. Now, the treatment strategies also depend upon the understanding of what kind of DIC we are dealing with. The main treatment, the mnemonic is treat the trigger in all DIC. In a bleed DIC, give support system with PRBC and SDP transfusion. In organ failure, block. What to block? Block the coagulation parameter with heparin. So the treatment strategies, I have taken this from ISTH article only. They say to treat the underlying condition in all kind of DIC, give FFP in bleeding and massive bleeding type DIC. antifibrinolytics like tranexamic acid are recommended for bleeding and massive bleeding type, because there you can cut the x-axis vector, while the synthetic protease inhibitors like nafamostate and gabaxilate, they if you are giving a protease inhibitor, you are eventually going to have somewhat control in bleeding. So in a bleeding type DIC, in a obstetric emergency, there is some role of nafamostat now. The natural protease inhibitor is, they've not given as such any recommendation on it, and anti-10A monitoring is not recommended in any kind of DIC. And in heparin is recommended if you are having an organ failure type DIC, but you have to make sure that you are reaching the right diagnosis of an organ failure type DIC, and that can only come after you have ruled out the other differentials and you are confirmed that we are dealing with a organ failure type sepsis related or any other organ failure type DIC, while thromboprophylaxis is suggested in non-symptomatic DIC. The third question, shall we take the third question, sir?
Yes, Gurkit, please continue. We'll
Okay,
discuss
okay,
at
I'll
the end,
just continue then. And the third question is HLH, the diagnostic criteria, the first part. The second part is secondary HLH in ICU, the triggers and note on secondary HLH. And the third part of the question is management modalities of HLH. So HLH definition we have taken from H score and secondary HLH. So the standard HLH definition is an uncommon life-threatening hyperinflammatory syndrome caused by severe hypercytokinemia due to highly stimulated but ineffective immune response. So the diagnosis of HLH need either a molecular diagnosis or fulfillment of a clinical criteria, which we have taken as 5 out of 8 for HLH 2004. Now, HLH 2004 criteria takes into account that number one, fever, splenomegaly, cytopenia affecting two lines, hypertriglyceridemia, hemophagocytosis, low or absent natural killer cell activity, ferritin levels are elevated interleukin 2 receptor. Now, they have given some thresholds of it to describe in HLH criteria. So before going into more detail of HLH 2004 criteria, we have to know certain things about HLH. Important ones are that in ICUs, we deal with secondary HLH. Genetic HLH, we rarely see in ICU. Ferritin is often extremely elevated in secondary or in all kind of HLH. And soluble CD25 and natural killer cell activities are specialized tests. They are often delayed, but are very important for making a lab diagnosis of HLH. Now the H-score has been validated tool to estimate the probability of secondary HLH in ICU setting compared to primary. And the fact that H-score parameters are more cohesive to make an H-score HLH diagnosis in ICU settings, because most of the patients we deal with in ICU where we are suspecting HLH, either they are going to have an 18-point score if we are suspecting immunosuppression, temperature, organomegaly, number of cytopenias. If we are having three lineage of cytopenia, the 34 score will be given to it. And the ferritin level, if it is more than 6,000, we are giving 50 score as per the H score parameter. Now H score has been validated in ICU, while HLH 2004 criteria has been validated for primary HLH. So you have to know both HLH 2004 criteria and H score separately as a topic. The triglyceride levels are important. These are given in millimoles, but if you convert it, this triglyceride level will come around 800. The fibrinogen level of more than 2.5, less than 2.5, and AST levels. Now, if you see that other than that, there are three in ICU, you can still get a very nice score of or more than 200 to make a diagnosis of HLH. So as I've already that it is designed for secondary HLH more practical than 2004 and can guide in treatment decisions because the treatment of secondary HLH is different somewhat from primary. The common triggers in ICU will be infection, bacterial, sepsis, SARS-CoV, Epstein-Barr virus, malignancies, autoimmune causes which are coming to ICU or post-transplant patients, and most important one is lymphomas we see in ICU. And the clinical presentation will be very much just like sepsis only. It is a mimicker of sepsis, so making a diagnosis is very tricky. Patient will have persistent fever, cytopenias, hepatosplenomegaly, hyperferritinemia, liver dysfunction. But now this is here the part that you have to make sure that you can rule out sepsis. And if it is not responding to antibiotics, and if you do ferritins and you do triglycerides, then your H score is going to come high, and then you can make a diagnosis of HLH. Now, this is again a repetition of diagnostic criteria of HLH 2004 and H score to be used in ICU. The important slide here is that ferritin levels have got a very good sensitivity, though less specificity for HLH here. Now, HLH management here is treat the trigger, number 2 immunomodulation, and number 3 supportive care. So it is easy way to remember the management of HLH for exam point of view. Treat the trigger, antimicrobial, chemotherapy for malignancy, immunosuppression for and immunomodulation will be dependent upon HLH directed therapy, which we will discuss in the next part, and the supportive care. The key ICU challenges, as I've already said, is secondary HLH versus sepsis. They overlap significantly and it looked like septic shock but worsened despite antibiotics. Secondary HLH in ICU mimics that we've already discussed. So the HLH algorithm we will treat, it has got 4 steps. Suspect an HLH, confirm, strongly suspect, immediate actions, treat accordingly, or step 5 is rescue or adjuncts if there is no response. So suspect, as we have already said, use H scores, apply them. In ICU, don't wait for all criterias. Immediate action, stabilization, airway breathing, circulation. Search for trigger, eliminate the trigger. Step 4 is secondary HLH, infection related. Go for antibiotic, antiviral, antifungal. Malignancy, start chemotherapy. Autoimmune related, steroid plus cyclosporin. Now, this has got a HLH 2004 and 94 protocol has been advised for management of HLH. As per HLH 2004, the dexamethasone dose in week 1 is 10 milligram per meter square. In week 2, to taper to 5 milligram per meter square, and as it is 2.5 and 1.25. Now, the changes from HLH 94 and 2004 are expected to be known. For exam point of view, that cyclosporin had been added, and they have added intrathecal steroid because lately we have seen that HLH patients have got neuro involvement and they've started using intrathecal methotrexate as well as intrathecal steroids. And in continuation therapy, they have made some changes in the pulse dose and the second week continuation of etoposide and cyclosporin. In short, HLH 2004 is steroid plus etoposide plus cyclosporin plus intrathecal therapy for 40 weeks with hematopoietic stem cell transplant for primary or refractory cases, which we don't see, which will not be expected to be seen that much in ICU. Now, the fourth question is plasmapheresis. It has got 3 parts. Part 1, it will be like I think of 6 marks. The indication, 2 marks, procedure, replacement fluid, complications and monitoring. And then IVIG is a separate question of 4 marks. I think 2 marks will be of mechanism of action, dosing regime, and evidences. So I have just taken this slide because I remember that the residents got confused when it was asked in the exam, plasmapheresis and not plasma exchange. So I have taken this slide. So a procedure in which blood of patient or donor is passed through a medical device which separates one or more components of blood and retains the remainder with or without extracorporeal treatment or replacement is apheresis, while a plasmapheresis is a procedure in which blood of the patient or the donor is passed through a medical device which separates plasma from other components of blood, and the plasma is removed without the use of colloid replacement solution is plasmapheresis. And when you are replacing the replacement solution, then it becomes plasma exchange. Okay. The plasma is removed and replaced with the replacement solution. So the definition of plasma exchange completes. The circle is completed. Now the mechanism of action is removal of pathological antibodies, cytokines, immune complexes, stimulates the proliferation of B cells, replacement of missing plasma components such as Adamets 13, as we have already discussed in first question. Now, the important principles to know is that substance targeted for removal must have a sufficiently long half-life. The substance to be removed must be acutely toxic and resistant to conventional therapy like CRRT, and should be sufficiently large with a molecular weight greater than 15,000 Dalton. Sorry, 1,50,000 Dalton. I think it has to be very high molecular weight. That is why it can be removed by plasmapheresis. So pathologic substances to be removed by therapeutic apheresis are immunoglobulins, and there are evidences of that in the hyperviscosity syndrome or autoantibodies. The level 1 evidence for myasthenia gravis and TTP in ICU, anti-GBM antibodies. We have covered this separately. I'll just category 1. But the things to be removed by plasma exchange are immunoglobulins, autoantibodies, lipoproteins, leukocytes, platelets, circulating immune complex, and protein-bound substances and parasites. So the category 1 indications in ICU will be of GB syndrome, TTP, microangiopathic hemolytic anemia, and AHUS, and acute liver. And the part of the question that was left was plasma exchange in procedure itself. It has got like 7 to 8 steps: the vascular access, the anticoagulation, volume to be exchanged, replacement fluid to be used, frequency to be prescribed, the duration of sessions to be prescribed, and general monitoring expected for us to know, and complications. So the vascular access, we all know anticoagulation, usually we use citrate or heparin depending upon the type of machine we are using. We will discuss about that later. And plasma volume typically prescribed are 1 to 1.5 plasma volume or 40 to 60 ml per kg. And albumin 5% is used as a replacement fluid or fresh frozen plasma for TTP, because we have to give new Adamets 13 because we are already getting rid of the Adamets 13, which is not working for us, having antibodies and the deficiency component. So we give FFPs for TTP as well as for atypical HUS also. Now frequency is whether like for TTP, we are going for 5 to 7 cycles. And whether the prolongation, we are prolonging the sessions, and the monitoring which is expected of us is that dyselectrolytemia, especially hypocalcemia, phosphate to be remembered, and hypotension and bleeding, coagulopathy, and infection and line site problems to be addressed. Now the methods of plasmapheresis is also a like 2 marks question. So centrifugal separation, or whether you are using membrane filtration, we have to know that centrifugal force, in which the centrifugal force is used to get rid of plasma from blood cells based on the density differences. While in plasma filter, the separated plasma from the cellular component is used, while there is the double filtration plasmapheresis, in which the plasma is separated by a membrane filter and then passed through a second filter to selectively remove the large molecules like antibodies and immune complexes. Then there is immunoadsorption, and the cryopheresis is there, and adsorption columns had also been used. Like adsorption columns are more used for drug overdose and poisoning components. Now, complication of plasmapheresis, like we've already discussed a little bit, but now we have just revised it again here. The hemodynamics, vascular, metabolic, hematologic, allergic, infectious, and other, you have to remember it like that. That way you can secure your 2 numbers. And the monitoring expected is minimum basics to remember, and to go from metabolism to coagulation to renal to liver to allergy and line sites. And there are reasons for that also. Now the IVIG mechanism and evidence and indication is another like 4 marks question. So IVIG mechanism of action is a purified preparation of pooled IgG antibodies from healthy donor. It has multiple immunomodulatory components like FC receptor blockade, anti-idiopathic antibodies, complement inhibition, cytokine modulation, and passive immunity. IVIG dosing regimes, which are generally prescribed in ICU, are of for GB syndrome, myasthenic crisis, and for Namdar encephalitis. 2 gram per kg for NMDR encephalitis. In GB syndromes, like 0.4 gram per kg per day. We have taken this from standard guidelines on apheresis from hematology only. Myasthenia gravis, 2 gram per kg. And ITP, we have already discussed that in ITP component at 1 gram per kg per day. And then IVIG evidences in ICU, where we have the hard evidences that of multiple RCT and Cochrane reviews of 2014 for GB syndrome. IVIG is easier to administer, and but there is no it is as effective as plasma exchange and not a superiority over plasma exchange. Myasthenia crisis, we have RCT and meta-analysis that show IVIG and plasma exchange have comparable efficacies in myasthenia crisis. And we have for Kawasaki disease also. Other than that, in ICU, the IVIG indications could be toxic shock syndrome from gram positive and Clostridium difficile and HLH. Thank you. Anything we want to cover left?
So thank you, Dr. Gurkirat. You covered the topic extensively. I hand over to Dr. Arindam sir to conclude. Yeah.
No, I think all the three speakers were excellent and such a grand, I would say, closing session of the entire 12 domains. And I was wondering that the amount of topics that we had to cover in our curriculum, I don't think any other super specialty has so much of uh, widespread syllabus. In fact, it's an infinite syllabus. Anything
Totally agree.
can, yes, anything can be a, because we are the custodian of all the specialities, critical situations. So anything can be put into as a question itself. So be it your oncology, your hematopath, trauma, toxicology, cardiac, respi, anything and everything, that the entire variation. So I feel pity for the students who are preparing now itself, so that they have to cover so much. So, and anything and everything can be any. And I was the first day when I entered my postdoc, and Dr. Rao said, you can identify sort of that when you are appearing for your exit exams of your postdoc, right? That's the last exams you are giving in your life. Right, after that you will be only taking exams. Okay, so you cannot complain for having or not having a syllabus itself. In fact, there is none. You can be asked anything and everything from your